We wish each one of them good morning, good afternoon, good evening to all the participants. Myself, again, Mr. Bhupati, the representing Inovine conferences, welcomes all our distinguished guests, dear doctors, scientists, educators, colleagues, friends, ladies and gentlemen. It is a great honor for me to welcome to join webinar on third virtual conference on physiotherapy, physical rehabilitation and sports medicine. We have completed successfully on day one of the conference. Today we are going to complete remaining day 2 of the conference. I would like to express my most sincere gratitude for your presence in this day 2 opening ceremony at the gateway to initiate to our scientific program. Once more, as well as once again, I am especially thankful to Mr. Kevin Brown, Mr. Madhu Bhupati, who have heavy burdens, duties and responsibilities to make this happen even today. I would also like to thank participants, especially those who are joining from miles, for sharing your valuable experience and ideas. With a good number of participants, I am sure this conference will be memorable, highly educational and not to be missed event. This webinar aims to provide an aid for people to share analysis and results about all the features of physiotherapy, especially the major topic will be physiotherapy, physical rehabilitation and sports medicine. Again, today we are going to cover the topics like physiotherapy science, sports physiotherapy, manual and manipulative therapy, artificial physiotherapy methods, women health care, palliative care, neurorehabilitation method, physiotherapy method instrumentation, experimental technique and therapies, physiotherapy in treatment care, advance in physiotherapy, rehabilitation method, physical medicine and rehabilitation, science and medicine in sports, physiotherapy in sport religious. Once again, I request all the participants, make sure to introduce everyone at the beginning. Ensure that you have clean, work appropriate background. Look into the camera when talking instead of looking at yourself. Be aware of your audio as well as video settings. And also, meanwhile, we ask you all the participants to keep mute of audio while speaking. Speaker is giving his or her talk. If you have any problem with uploading of your PPT, you can send to me, mention mail ID or WhatsApp number. We can play behalf of you. We have mentioned the so-and-so WhatsApp number as well as email ID. So now I request Dr. Tahmidir Abdullah Al-Josi from King Fahid Medical City from Rehabilitation Hospital Physiotherapy Department from Saudi Arabia. The topic will be fatigue, depression and anxiety among mobilizing multiple sclerosis patients.
Greeting everyone. I'm Tamadar Al-Joui, an outpatient physical therapist working in King Fahd Medical City in Riyadh, and I would like to present our research today, titled by Fatigue, Depression, and Anxiety Among Mobilizing Multiple Sclerosis Patients. And these are my team members. And first of all, multiple sclerosis is one of the most common neurological disorders that affect young adults, and it's a chronic inflammatory autoimmune disease that affects the central nervous system. It's an inflammation that leads to demyelination and axonal loss, manifesting as different cognitive, motor, or sensory symptoms depending on the region's location. MS patients it's more common in female more than male. While worldwide, the ratio is 3-1. And in case A, the ratio was estimated as 2-1 woman to men ratio. The current prevalence of MS in Kingdom of Saudi Arabia is estimated to be around 62 patients per 100,000 Saudi nationals. And it is observed that depression and anxiety, fatigue symptoms are common among people with MS, and it does affect their quality of life and physical activity. In some studies, the prevalence of depressive symptoms and anxiety is ranged between 14% up to 54%. And 14 up to 41% in different studies. Our objective in this study was to assess the prevalence of depression and anxiety and fatigue among people with MS in Saudi Arabia. Furthermore, this study intends to examine the correlation between these symptoms and the quality of life and physical activities. Our study design setting was that our study is a cross-sectional study. It's conducted in the neuroimmunology clinics in King Fahd Medical City, also in King Saud University Medical City, also in Prince Noura University Hospital. Also, our questionnaire was sent to patients from a database provided by ARFA Association. And this is a non-profit organization that helps people with MS, and it's approved by Saudi Ministry of Human Resources and Social Development. Our inclusion criteria was all patients aged from 18 years and above, with at least 1 year history of MS diagnosis, with no walking difficulty. Also, who had none history of relapse in the last 8 weeks. They were eligible to participate in the study, and we excluded the other patients since they will report high fatigue level, which leads to bias in our result. Our sample size was 323 patients. We started collecting our data by using a self-reported questionnaire, which contains the demographic data as the age, education, region, living in Saudi Arabia, work status, marital status. Also, we considered the clinical characteristics as the number of years after diagnosis, also the last MS relapse. We used these for outcome measure, hospital anxiety and depression scale, international physical activity questionnaire, European 5-dimension questionnaire, also fatigue severity scale. All these 4 outcome measures are valid and reliable in Arabic version. I will explain each outcome measure with the result, inshallah. Here is our descriptive statistics of the study sample. We divided our age groups, each 10 years together, from 18 to 29 and so on. And here is the regions: Central, Eastern, Western, Northern, and Southern Saudi Arabia. The nationality, the education, either secondary, diploma, university, postgraduate, also the work status. And here is the mean of our sample size number of years after they were diagnosed with MS. And the mean for the last MS relapse was 2 years and a half. First of all, the hospital and anxiety and depression scale. It contains 14 questions. 7 questions will measure anxiety, and 7 will measure depression. As you can see, each item is scored from 0 to 3. Then it will be calculated. The total score from 0 to 7 will consider as normal. From 8 to 10 will consider as a borderline case, and from 11 to 21 will consider as a case of anxiety or depression. Here is the Arabic version of HAD. It's validated after a pilot study, and it's also reliable. And here is our result. It also rated that the majority have normal levels. It also rated that 13% had depression, and 25% of our patient had anxiety. And our result is different than a previous study. For example, in Emirat, they had a study that showed and reported that depression and anxiety present among people with MS around 17% up to 20% of their patient. Also, another systematic review and meta-analysis found that the prevalence of depression was 30% among people with MS, while the prevalence of anxiety was 22%. Our patients who are aged from 18 to, in our sample size, who are aged from 18 to 29 or from 50 years and above, they had a higher mean score of anxiety than those who are in their 30s. Also, our result showed that patients who lived in the central or western regions in Saudi Arabia had significantly higher depression and anxiety scores than those who lives in the eastern region. Our second outcome measure is the short form of IPAC, and it consists of 7 questions that measures 3 different level of activities. It will measure the walking during the previous week. It measures the intensity of walking and moderate intensity activity, also the vigorous intensity through the previous week, also on a usual basis. It will be calculated by a special equation provided by IPAC website. and then the result will show that either the population is low or moderate and high level of activity, a level of physical activity according to their scoring system. And here is the Arabic version, which is also valid and reliable. Our results showed that the majority of our patients had high physical activity levels, which also makes sense because our sample size are all of our patients were mobilizing patients. The statistical differences of the mean scores showed also that the disease duration was positively and significantly correlated with total physical activity. The third outcome measure we used was the European Quality of Life 5 dimensions questionnaire, and it's globally used and translated to hundreds of languages. It consists of 2 parts. The first part measures 5 dimensions of life: mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. Each dimension will be scored, respond by 3 responses. Either they have no problem in this dimension, or some problems, or having extreme problems. The second part of our questionnaire, it's a general visual analog scale that's scored from 0 to 100, and simply they will be asked about their own health state for today. So it's a general impression of their well-being in that day. Okay, and here we have the Arabic version, which is also valid and reliable. And here is our results. It showed that in mobility, self-care, usual activities, the majority of our patients had no problem. From 74% up to 100 had no problems at all. And depression and anxiety, 50% had no problem. The interesting thing that the other half was more than the half of them were married patients, and they reported that they had some or extreme problems. In pain or discomfort dimension, 52% of our patients had some problems. And for the self-assessment, our mean score was 80%, and most participants exhibited a healthy state. And actually, our result is higher than that a previous result reported by a previous study, which is conducted in King Abdulaziz Medical City in Saudi Arabia. Their result showed a mean score of 73%. Fourth outcome measure we used is fatigue severity scale, and this was found to be sensitive, reliable, and consistent with people who have MS. It contains 9 statements describing the severity and impact of fatigue, with possible responses from 1 to 7, as one is a strongly disagree, and 7 is strongly agree. The total scores are usually reported as the mean score over the 9 items. Higher scores indicates higher severity of fatigue. And here is the Arabic version, which is also which showed acceptable psychometric properties. The result indicated that 48% out of our sample size reported fatigue. Also, it indicates that there were statistically significant association between fatigue severity and depression and anxiety that was measured previously by HADS. In different research, the prevalence of fatigue was higher than in our research, which is ranged in average between 50 up to 80%. Also, our study stratifies the fatigue levels and the prevalence based on the demographic data. As you can see, 75% of women in our data reported fatigue. Also, we have 57% of our sample size who were educated, university educated, reported fatigue. 67% of the central region were also report fatigue. The correlations between depression, anxiety, quality of life, fatigue, and IPAC was measured in our study, and the results showed that fatigue severity and depression was positively and significantly correlated with which indicates that higher fatigue severity level is associated with high level of depression. On the other hand, the IPAC scores was not significantly correlated with depression or anxiety or fatigue. Also, negative and significant correlation were found between quality of life and depression and anxiety and fatigue severity. In this study, we faced some limitation, which is we only used self-report assessment of fatigue, depression, anxiety, and quality of life and physical activity, which is not an actual psychiatric diagnosis. Nevertheless, that it showed an acceptable psychometric properties. Also, the questionnaires that used does not identify the type of physical activity which would inform the decisions. Also, this study did not take into account the role of social support and coping strategy for MS patient, which might affect the quality of our result. In conclusion, the result of this study is important for the improvement of the clinical management of MS patient. Furthermore, potential clinicians should have more focus on anxiety and depression symptoms among people with MS. to develop an appropriate treatment for those patients. Finally, we highly recommend support programs that be available for people with MS to ensure an adequate coping with the disease. Thank you all for your listening, and please let me know if you have any questions.
Yes. This was the presentation from Dr. Tamadir Abdullah. If you have any questions regarding this topic, just you can raise your hand and ask the questions. Dr. Tamidar is in online in Zoom meeting. Any questions to Dr. Tamidar? Any questions? Yes, madam, you have the question from Dr. Takroni. Thank you so much for this well organized study. Don't you think using 4 outcome measures were difficulty and you did not use active measures for activity like ADL?
Yes, actually, we used the short form of IPAC. It was consist of 7 questions only.
Yes, Dr. Takrin, did you? I think the answer is answered from Dr. Tamidir. Any further questions?
Hello, good morning. This is Dr. Takroni again.
Yes, sir.
First of all, thank you, Tamadar, for this well-organized study. My question was, most of the outcome measures were, subjectively. You didn't do any like active measure to see their walking distance, activity of daily living, or any of this. Activity measures, or that was difficult because it's a kind of cross-sectional study, and there is 3 organizations are involved in this study. Thank you so much.
Thank you for your question. And yes, it was kind of difficult because it's a cross-sectional study, and it was sent also for outside Riyadh, a patient who lives also outside Riyadh. As you know, some patients, they come to this organization from far away. Also, yes, we found this is the simplest way we can measure their quality of life and activity, daily life activity. So we put it also in the limitation that all of our outcome measure was a self-reported outcome measures.
Thank you so much.
Yes.
You're welcome.
Yes. Any questions? Any further questions to Dr. Tamidir? If you have any questions or comments, you can text here so that we can ask behalf of the participants even after the completion of the conference. Yes, madam. There is no questions. I think. Thank you so much, madam, for participating in this event. On behalf of Physiotherapy Congress 2021, we want to thank you for this presentation. Thank you for joining and for your attention. After the completion of the conference, within 3 to 4 days, you will be getting an electronic certificate as a booklet. Next speaker will be Dr. Kian Hu Lee and Xiong Chung Chong from Kongkang University from Republic of Korea. The topic will be assessments of muscle thickness and tonicity of the masseter and stereocleidomastoid muscles and maximum mouth opening in the patients with the temporomandibular disorder. Yes, sir, you can go ahead by sharing your slide. You can go ahead by sharing your slide. Yes, it's fine.
Yeah. Hi everyone.
Yes, sir.
The topic of today's poster is assessment of muscle thickness and tonicity of the masseter and sternocleidomastoid muscles and maximum mouth opening in patients with temporomandibular disorder. Let's start with the poster presentation. The main function of temporomandibular joint, such as mouth opening, chewing, and lateral movement, are controlled by the mastoid, temporal, pharygoid, and sternocleidomastoid, and lateral chewing is considered the most important function. The temporomandibular disorder, which show pain and functional movement problem, is reported to be experienced by about 75% of the population. In addition to the accompanying pain, malocclusion and crepitation frequently occur while TMD patients open their mouths. In this case, managing activity of daily living is not easy and quality of life may be affected. The aim of this study was to compare muscle thickness, tone, and maximum mouth opening of the masseter and SCM muscle between the TMD group and normal group using the above quantitative tools. In addition, we determine if there is a correlation between each factor like muscle thickness and tone of the masseter and SCM muscle and maximum mouth opening in the TMD group. Let's talk about materials and method. The study consisted of 60 adults over the age of 20 residing in metropolitan city were included as follows. 30 patients were assigned to an experimental group and 30 normal adults to a control group. An ultrasound device was used to measure the thickness of the masseter muscle and SCM in a relaxed and clenched state of the TMJ. A myotonometer was used to non-invasively measure the tone of the muscles around the TMJ. A digital vernier caliper was used to evaluate the maximum mouth opening of the TMJ. The general characteristics of the subject were expressed as mean and standard deviation using descriptive statistics to compare both groups. Independent t-tests were used to compare relaxed and clenched muscle thickness, muscle tone, and maximum mouth opening in both groups. First correlation analysis was used to evaluate correlation among muscle thickness, muscle tone, and maximum mouth opening. Let's talk about result. The experimental group revealed a significant decrease than the control group in the muscle thickness of masseter and SCM, respectively, which a significant increase in frequency and stiffness. In the masseter muscle tone, with which a significant increase in frequency and stiffness in the SCM muscle tone. A significant decrease in the maximum mouth opening. There was There was a moderate negative correlation between relaxed state of masseter, muscle thickness, and stiffness of SCM muscle tone, and a moderate negative correlation between relaxed state of SCM muscle thickness and frequency of SCM muscle tone. There was moderate negative correlation between clenching state of SCM muscle thickness and frequency of SCM muscle tone. In addition, a moderate negative correlation between maximum mass opening and frequency of SCM muscle tone. The limitation of this study are as follows. First, the results of this study cannot be generalized because the sample was limited to a small sample size. Second, only a one-sided comparison of the TMJ was performed, not a both-sided comparison. Therefore, a study investigating the comparison of TMD or non-TMD on a large number of subjects with both sides of TMJ is needed in order to fully elucidate the clinical benefit for a wide range of subjects, including temporalis and pterygoid muscle. This study provides empirical evidence to show that the TMD group decreased the thickness of the masseter and SCM muscles. In addition, the tone of the masseter and SCM muscle increased, and maximum mass opening decreased. Finally, there were moderate negative results between the maximum mass opening and stiffness of masseter muscle tone. There were moderate negative results between the maximum mass opening and frequency of SCM muscles tone. Therefore, when planning exercise program and treatment for TMD patient, efforts to reduce tone of the masseter and SCM muscles are expected to help improve jaw opening. Thank you for listening. Please contact me via email if you have any question due to time constraints. Thank you.
Yes. This was the poster presentation from Dr. Kian Hooley. Any questions regarding this topic? This was the poster presentation. Any questions regarding this topic? Yes. Yes, thank you very much, sir, for participating in this event. On behalf of Organizing Committee members of Physiotherapy Congress 2021, we want to thank you for this presentation. Thank you for your sharing your PPT with us. Looking forward to meeting again next time. Next, we ask Dr. Abdullah Ahmad Elisa, Faculty of Medical Rehabilitation Science, King Abdulaziz University. From Saudi Arabia.
I'm gonna thank you so much. I'm gonna share my screen. Okay. Good morning or good afternoon, doctors, professors, experts, senior, junior, physical therapist. Thank you for being here today. I'm Abdullah Isa, a master student in King Abdulaziz University, Jeddah. I'm here today to talk to you about my research titled with Factors Considered for Safe Return to Sports and Adherence of Criteria after ACL reconstruction, physical therapist perspective. Anterior cruciate ligament injury, ACL injury, is common among professional athletes, especially those demanding physical activities. The injury results from situation where the knee is hyperextended or twisted forcefully. Most of the cases, ACL reconstruction is performed to repair the damaged ligament, following which the rehabilitation is necessary for the safe return to activity or sports. The objective of our study was to identify various factors affecting safe return to sport and adherence criteria following an ACL rehabilitation among physical therapists PTs in Saudi Arabia. The study was cross-sectional, conducted among 234 PTs who have experience in ACL rehabilitation. Both males and females have a minimum of 1 year of experience in ACL rehabilitation. For the methods, I'm going to zoom in. First, design and develop the questionnaire. The questions of the questionnaire were quoted from literature, then were written, after that translated in Arabic language. So the questionnaire was in both language, Arabic and English. Next step, testing the content and face validity. The first draft of questionnaire was circulated to physical experts for testing the content validity and also for reviewing the translation. Grading for the content validity from 1 to 4. Grade 1, the item or question is not relevant. Grade 4, the question or item is highly relevant. After that, the questionnaire, the first draft, circulated to physical therapists, 13 physical therapists, for testing the face validity and also reviewing the clarity of the question, because the survey would be for the physical therapist. Again, for the face validity, the grading from 1 to 4. Grade 1, the question or item is not clear and ununderstandable. Grade 4, the question is clear and understandable. After that, next step, the questionnaire was dropped in Google form and survey conducted online via social media, WhatsApp, Twitter, Instagram, Telegram. And the duration for finishing the survey was 7 minutes. Next, we received about 336 responses. However, the eligible and included therapists, 234. Next, for the data analysis, we used SPSS for the data analysis. And the analysis based on 3 categories. We categorized the physical therapists into 3 groups: musculoskeletal and non-musculoskeletal, and qualification with multiple factors. The qualification, we divided into bachelor and master. Okay, for the results. Okay. move to this. Yes. Here we go. For the results, I'm gonna zoom in. Here we go. Time for safe return to sport. 46.5% of musculoskeletal of musculoskeletal BTs choose 6 to 9 months. Time for safe return to sport. For the non-musculoskeletal, 45.9% of non-musculoskeletal BTs choose 6 to 9 months. Next, age influences safe return to sport. 90.1% of musculoskeletal BTs agreed age influences. For the non-musculoskeletal, 86.5% of non-musculoskeletal BTs agreed age influences. Psychological support, almost the same. 98% of musculoskeletal BTs choose yes. Likewise, non-musculoskeletal BTs, 96.2% of non-musculoskeletal BTs choose yes. Psychological support must for safe return to sport. Patient adherence to rehabilitation. 98% of musculoskeletal BTs choose yes. Patient adherence to rehabilitation affects. For non-musculoskeletal BTs, 92.5% of non-musculoskeletal BTs choose yes. Patient adherence to rehabilitation affects safe return to sport. Return to sport after ACL reconstruction lead to injury? Here's the answer. Musculoskeletal BTs, 39.6% of musculoskeletal BTs choose yes. However, 33.7% of musculoskeletal BTs choose no. May not lead to injury. Whereas 26.7% of musculoskeletal BTs were not sure, may lead or may not. For the non-musculoskeletal, 42.2% of non-musculoskeletal BTs were not sure. Return to sport after ACL reconstruction lead to injury or not. However, 28.6% of non-musculoskeletal BTs choose no, may not lead. However, 29.3% of non-musculoskeletal BTs choose yes, may lead to injury. For the barriers and management for safe return to sport, 52.5% of musculoskeletal BTs haven't faced any barriers. For the non-musculoskeletal BTs, 57.1% of non-musculoskeletal BTs haven't faced barriers in the management for safe return to sport. Other category for the qualification, bachelor and master. 48.9% of bachelor PTs choose 6 to 9 months, ideal time for safe return to sport. For the masters BTs, 38.3% of masters BT choose 6 to 9 months ideal time for safe return to sport. Age influences, almost the same, bachelor and master. 88.5% of bachelor BTs agreed age influences. Likewise for the master, 86.7% of master's BT agreed age influences for the safe return to sport. Psychological support, almost the same. 97.1% of bachelor BTs choose yes, psychological support must for safe return to sport. For the masters, 96.7% of masters BT choose yes, psychological support must. Patient adherence to rehabilitation affects for the safe return to sport for the almost the same, bachelor and master. 94.8% of bachelor BTs choose yes. Likewise, for the masters, 95% of masters BT choose yes. Patient adherence to rehabilitation affects for the safe return to sport. Return to sport after ACL reconstruction lead to injury? Here's the answer. For the bachelor, 33.3 choose yes. However, 27% of bachelor BT choose no. However, 39.7% of bachelor BTs were not sure. For the masters, 41.7% of masters BT choose no, may not lead to injury. Whereas 35% of masters BT choose yes, may lead to injury. However, 23.3% of masters BT were not sure, may lead to injury or may not. Barriers in the management for the safe return to sport, almost the same for the masters and bachelor. 55.2% of bachelor BT haven't faced any barriers. Likewise for the master, 55% of masters BT haven't faced any barriers in the management for the safe return to sport. The conclusion of our study: all the musculoskeletal, non-musculoskeletal BTs and undergraduate, bachelor, and master qualified BTs agree, sorry for this mistake, agree upon the factors mentioned below for the safe return to sport after ACL reconstruction. First, ideal time for safe return to sport is 6 to 9 months. Second, age can influence the safe return to sport. Third, psychological support is mandatory for safe return to sport. Fourth, patient adherence to rehabilitation affects the safe return to sport. Sixth, felt no barriers in the management for the safe return to sport. However, 1/3 of the BTs feel that return to sport after ACL reconstruction may lead to secondary injury. I would like to thank my supervisor, Dr. Muhammad Faisal, and Dr. Fayyaz Khan, and the participants, senior, junior, physical therapist, for supporting me for the successful completion of this research. And thank you for listening.
Yes, this was a presentation from Dr. Abdullah Ahmad Alisa. Any questions regarding this topic? Any questions? If you have questions regarding this topic, even after the completion of the conference, you can mail us. We'll be sending to concerned speaker. You will be getting answers within 3 to 4 days. Yes. Thank you so much, sir. Thank you so much for speaking in this meeting and providing a unique perspective. Thanks for sharing your tips with us. Looking forward to meet again next time.
You're welcome.
Yes. The next speaker for our conference will be Dr. Chiras Al Jabarni, physiotherapist from Qatar. The topic will be Milli method for treating baby clubfoot holistic approach. Yes, madam, you can start sharing your slide from your side.
Hello? Do you hear me?
Yes, you can start sharing your slide.
Okay. So I will start. Okay, can you see it?
It's fine.
First of all, I would like to welcome all the attendees and would like to introduce myself. So my name is Shiraz Al Jobrani. I am a physiotherapist, Tunisian physiotherapist working in Qatar. I have 18 years of experience in the field of pediatric and including 13 years in Qatar. So this method that I just have discovered and tried with my patient, and I can say that it works perfectly. That's why I would like to share it with the world. Disclosure, I have no actual or potential conflict of interest in relation with Dr. Mili. I will be discussing off-label uses of the following materials: kinesiotape and plaster cast. The plan of the presentation will be, I will go a quick definition of the clubfoot, treatment, the 3 techniques, and I will go through each technique, the first 2 briefly and deeply in the Mili technique. I make a comparison table, we will discuss it, and a conclusion. So let's go quickly in the definition of clubfoot that most of you knows, but if someone, I will refresh a little bit the memory. So clubfoot is a congenital triple deformity of the baby's foot, usually detected at birth with an occurrence of 1 to 4 per 1,000. It is the most common birth defects. It can be bilateral or unilateral, mild or severe. This triple deformity, known as clubfoot, occurs in 3 planes of the space. On the first plane, the frontal plane, varus of the hind foot, which is the major deformity. On the second plane, the transversal plane, medial rotation of the calcaneopedial block, which is an adduction of the forefoot. On the third plane, the sagittal plane, the ankle equine, which is a plantar flexion of the foot with Achilles tendon shortness. Clubfoot is also known under the name of talipes equinovarus. The 3 deformity is shown here in the picture. You can see it. The foot goes down and in with the shortness of the Achilles tendon. So, just a second. The treatment of clubfoot is only and exclusively physiotherapy at the first stage during the first month of the baby's age. There are not many ways to treat it. Actually, we count only 3 techniques. I count 3 techniques, but usually it counts 2 techniques, the techniques that known most in the world, the classic techniques, which is first the French methods, second the Ponseti method, and the most recent technique is the Mealy method. About the French technique, as a reminder only. The French methods consist of daily passive manipulation of the newborn's club foot. It aims to immobilize the foot with elastic and non-elastic adhesive taping, as seen in these pictures. The treatment starts at the age of 3 weeks old. And in some countries, just like the country I am living in, Qatar, they start this technique treatment at the age of 2 months. Splinting is a necessary phase in this type of treatment. The splint is first is daily splint, after that it will be a night splint, as in this picture. Costs. It is considered high to medium cost-effective technique in low-income and middle-income countries. It is important to see also the cost, not only the technique. Ponseti technique. It is the most famous technique worldwide. The treatment is based on a serial cast, about 4 to 5 casts for mild cases, and sometimes until 9 casts for the most severe ones. In fact, the physiotherapist apply passive manipulation of baby's foot, leading to a correct positioning of bones. Sadly, in 50% of cases, the need of a surgery is imperative to fix the Achilles tendon. Babies has to wear night splint for 3 to 4 years to prevent recidivism. This kind of splint, which is called Ponseti splint. Cost effective. Considered very high cost effective compared with many other global health conditions. So here we are, Mealy methods for clubfoot. First of all, let me introduce Mr. Mealy, a small and quick biography. So Dr. Fraj Mealy is a Tunisian physiotherapist with over 40 years of experience in the field of neuropediatric. He is known as the specialist of congenital distal deformity in babies, such as foot and hand. He worked as a chief of pediatric rehabilitation department in a public hospital in Tunisia. And nowadays he works in his own clinic specialized in neuropediatrics. Mealy method birth. Dr. Mealy invented his technique on treating baby clubfoot in 2008. He won the Super Prize of Tunisian Inventor the same year for this revolutionary technique. Let's have some statistic. So patient benefits of Mealy technique are over 1,200 patients, 100% of success when the treatment is done within good conditions, 1% only of failure, or let's say imperfection, due to wrong treatment conditions. Only 5 countries in the world are benefiting from this method. 5 countries, which are Tunisia, Algeria, Morocco, Libya, and Italy. This method has 4 approaches. The first approach is in utero treatment. That means the treatment starts before baby's birth, almost at the 3rd month of pregnancy. The second approach is the newborn approach, which starts treatment at the 1st week, sometimes before 3rd day or 4th. The third approach, which is For severe and complicated clubfoot, it starts at 6th month. And the fourth approach is for the inveterate clubfoot, the cases that has failure of any passive correction attempt. So I will be only describing the second approach, which is only considering the newborn, because of lack of time, and it's not possible to go through all these approaches in only 15 or 20 minutes. So how does it work? This method has reversed the principle of treatment of distal congenital malformation. In fact, the treatment techniques goes from passive isometric to active dynamic. This allows the physical therapist to treat this deformity without pain and damage of the skeleton, the foot skeleton, the bones. Mealy method uses hypoallergenic tapes to correct the deviation and goes beyond the foot and ankle for better action. When I say beyond the foot and ankle to better action, I mean he goes on the knee. He starts the treatments from the knee. As the tape is flexible, this allows the baby to move well and gives him a certain degree of freedom in motion. The baby then actively corrects the position of his foot by controlling the pain threshold and without hurting himself. This method highly respects the morphogenesis of foot bones. That explains why Mealy starts his correction by the beginning of the foot morphogenesis. I will share with you some video, some cases. Let's start by the first one. Here is a newborn baby. He had unilateral clubfoot. Only the left foot. You can see here. Very severe case. I would like to show you the X-ray. As you can see the bones here, how they are displayed. It's a unilateral club foot, only the left foot. You will see this is the before, you will see the after. Here is another case, a small, only 2 days old, with a severe bilateral club foot. And here is at the age of 1 month. After 5 sessions only, you can see the alignment of the leg and the foot, the ankle. I would like to share also some video. Here is me working, trying the Mealy method. Baby Rima here, she has only 5 days old. the taping goes from the toe till the knee. And here is a very severe case that the case from phase 4, inveterate case. I would like to share it with you. It's not included in our presentation, but I would like to share it because it's a really amazing work, something unbelievable. She's 10 years old. You can see how severe it is. After only 6 sessions, of course, without surgery, without splint, without casts, pain-free, she can walk normally, aligned food. This is really unbelievable. So here is the comparison. Between the 3 methods, Ponseti, French, and Mili. So for the beginning of the treatment, for Ponseti and French, starts from 3rd week and sometimes from the 2nd month. As I said, in some policy of in health in some countries, they start the treatment at the 2nd month. For Mili method, it starts from the 1st week, sometimes from 3, 4, 5 first day of life. The treatment period for Ponseti lasts for 4 years. The French technique, 2 years, between 1 to 2 years. For Mili method, if it starts, for example, in the second phase, which is newborn, if he starts at 1st week, he will finish 5 months, 6 months, maximum 1 year. All time. In Ponseti method, they use plaster casts and splints, night splints. The French technique, they also, despite in addition to manual technique, they also use the splints and tapes also. Mili tapes only, hypoallergenic tapes. Manipulation of the baby food is passive manipulation in both Ponseti and French. For Mili, it's only active and passive is banned. Interdiction to use passive techniques. The muscle, so it works isometric for both Ponseti and French and dynamic in the Mili methods. Of course, pain, there is pain in both Ponseti and French, and for Mili, it is pain-free technique. Need of surgery? Yes, in 50% of cases in Ponseti and French technique, they have to go under surgery to fix the Achilles tendon, the shortness, the Achilles tendon. For Mili method, this is not occurred. No surgery for Mili methods. So as I say, it is personal, but as I can say, no respect for morphogenesis for both Ponseti and French, and high respect morphogenesis with Mili methods. As a conclusion of the table, I can say that, excuse me, the first 2 methods, Ponseti and French, start the rehabilitation by the 3rd week after birth. They both concentrate on treating the major deformity, which is the varus, while the equine is left behind for an eventual surgery later in 50% of the cases. Achilles tenotomy. Mili method has 5 major innovations: dynamic and active, with self-control of pain threshold, active traction of the calcaneus. That's why there is no need for surgery for the Achilles tendon, and the continuous functional self-education, And this special simultaneous correction of the three components of the clubfoot, the three components, I mean the varus, the equine, and adductus. The three components are simultaneously corrected by the Mealy methods. Description of the foot morphogenesis. This is the Mealy method, and as you can see, by the Mealy methods, only manually, without surgery, without splint, without anything that can hurt the babies, it works perfectly. So there is a question that I'm still asking, a big question, which is why surgical when manual works perfectly? And I don't know why people still go into surgery when it's perfectly done, perfectly, and have amazing results only by manual. I will let this question and the answer for you to answer on it, because I cannot find an answer. Here is some references. And I would like to invite you to know more about Mealy method. You can reach out to him by email. This is his mobile and site. And also, please feel free for any collaboration with me. This is email, WhatsApp, LinkedIn, and Instagram. Thank you very much for your attention.
Yes. This was the presentation from Dr. Cheers. Any questions regarding this topic? Any questions? If you have any questions, you can text in chat box. We'll be asking behalf of you, even after the completion of the conference.
Yes, they can reach out to by email.
Yes,
for
madam.
any collaboration or to know more about the Mealy method. It deserves to be known. It deserves to be worldwide known and recognized.
Yes, yes, madam.
Thank you very much.
Yes. Due to some busy schedule, they were not joining the Zoom meeting. And as soon as completing their talk, they are leaving. That's the drawback. So thank you so much, madam, for sharing your tips with us and providing a unique perspective. Thanks for sharing your tips with us. Looking forward to meeting in physical event if everything goes well in 2022. We are planning in Dubai in the month of May. If you wish to go to event as a workshop presentation, you can get ready from now itself. Yes. Thank you so much, madam. Have a nice day.
Thank you too. Bye.
Next speaker will be Dr. Irina Kola from University of Medicine, Faculty of Medical Technical Science from Albania. The topic will be the efficacy of manual therapy in patients with temporomandibular artificial disorders.
Hello, I am Irina Kola. I am a rheumatologist and physiotherapist. I work as a professor in the Faculty of Technical Medical Sciences in the University of Medicine, Tirana. I am very honored to be part of this conference, and I am hoping that you will find my presentation useful and interesting. So let's begin with my presentation. The efficacy of manual therapy in patients with temporomandibular joint disorders. Literature review. Temporomandibular disorder is a broad term involving disorders of temporomandibular joint and accompanying anatomical structures. This disorder requires a complex treatment that always involves both manual therapy and other modalities used to improve the patient's health. Temporomandibular joint is a complex joint due to its structure and movements. It is the only mobile joint in skull. The temporomandibular joint performs combined movements such as front, back, lateral dexter and sinister, inclination, and light rotation. Imbalance or damage of the temporomandibular joint can lead to articular, muscular, and neuromuscular dysfunction, especially of the masseter muscle. The term temporary disorder of the temporomandibular joint is recognized and endorsed by the American Dental Research Association. Disorders of the temporomandibular joint have various causes such as genetic predisposition, occlusal changes, stress, anxiety, and anomalies such as intra-articular disc incongruence, inflammation, muscle damage and pain, or muscle spasms. Clinic: articular noise during movement, headache, preauricular pain, otalgia, neck pain, facial muscle pain, muscle fatigue, deviation of the jaw trajectory, restriction in mouth opening. All these cause decreased life quality. The male-female ratio, it is noticed that women are affected more due to hormonal changes and menopause, which is accompanied by a decrease of estrogen, which causes osteoporosis. The conservative treatment plan aims the improving of life quality. Manual therapy, modalities, speech therapy should adapt conservative practices. Patients perform orofacial myofunctional exercises to balance the orofacial musculature, helping in this way oral functions such as chewing. This therapy works by reducing the overload coming from orofacial muscle adjustments and compensations, which aggravate the activity of the temporomandibular joint. The purpose of treatment is to reduce pain, adjust the range of motion of the mandible, recovery of the orofacial muscle system. The research is limited to articles published in electronic databases between January 2001 and December 2019. The purpose of this study is systematic review of the literature concerning treatment of pain, evaluation and effectiveness of the techniques used, in particular the use of orofacial myofunctional therapy, functionality of the temporomandibular joint in various areas of health care. Methodology. This study is a literature review conducted in 6 electronic databases such as PubMed, ScienceDirect, Wiley Online Library, etc. The articles obtained from the online databases were in English. The study is limited in articles published from 2001 to 2019. Our study includes randomized, experimental, and case studies. The selected cases were diagnosed with temporary temporomandibular and oral joint disorders. The Pedro scale was used to evaluate the literature. They had practiced manual therapy, modalities, speech therapy, and use of equipment to treat temporomandibular disorder. In the selected articles are analyzed evaluation case by case, age, gender of participants, rehabilitation of the temporomandibular joint. 19 articles are reviewed between 48 articles available. These articles are divided in articles in the field of dentistry, articles based on speech therapy, articles that are based on manual therapy, articles that mainly review the clinic. Among the articles from the field of dentistry, the age of the participant was similar, varying between 20 and 55 years old. Two of the studies involved the use of occlusal circuits, and another study implemented an exercise protocol. The technique used and the description of the therapy are detailed in all articles. The study by Truelove has long-term monitoring after 3 and 12 months of treatment. Other studies present only pre-intervention and post-intervention data. Regarding the methods used for diagnosis, all studies have protocols such as diagnostic criteria for temporomandibular disorders, surface electromyography, image scanner, and mandibular range measurement. Regarding rehabilitation, no corresponding therapeutic differences were found. One study shows that chewing gum is exercise that reduces pain and improves functionality in patients with temporomandibular disorder. However, the study uses evaluation only before and immediately after treatment. Therefore, it could not confirm the results in long terms. In the field of speech therapy, participants are spread in a more wide range of age, between 13 and 68 years old. Some studies have used two groups of patients. In group 1, there were patients with temporomandibular disorders, and group 2, there were only healthy individuals as control groups. Speech therapy is found that reduces the symptoms of temporomandibular disorder. Low-intensity laser therapy with or without myofunctional therapy. Most studies examine the patient before and after treatment. Only Melchior and Mikado study did long-term evaluation. Studies have shown that laser therapy only relieves pain, but not orofacial muscle function. Orofacial myofunctional therapy was associated with a significant improvement in pain and mandibular mobility and orofacial muscles function in general. The combination of laser therapy and myofunctional therapy was more effective than laser therapy alone. In the following slides, I am presenting some temporomandibular joint mobilization exercises, which I use to treat the patients with IR. In addition to AINS and AIS treatment, I use the following exercises as well. The effects are quite satisfying. So, goldfish exercise 1, partial opening. Keep tongue on the roof of your mouth. Place one index finger on the temporomandibular joint. Place your other index finger on your chin. Allow the lower jaw to partially drop down and back with help from the index finger. Monitor this partial jaw opening in a mirror to make sure the opening is straight. Tongue stays up. Repeat 6 times a day. Goldfish exercise 2, partial opening. Keep tongue on the roof of your mouth. Place one finger on each temporomandibular joint. Allow the lower jaw to partially drop down and back to bring the chin to the throat. Monitor this partial jaw opening in a mirror to make sure the opening is straight. Repeat 6 times a day. Goldfish exercise 3, it's a full opening exercise. Keep tongue on the roof of your mouth. Place one index finger on the temporomandibular joint. Place your other index finger on your chin. Allow the lower jaw to fully drop down and back with help from the index finger. Monitor this full jaw opening in a mirror to make sure the opening is straight. Tongue stays up. Progression. Perform with tongue dropped off the roof of the mouth. Goldfish exercise 4, it's a full opening exercise. Keep tongue on the roof of your mouth. Place one finger on each temporomandibular joint. Allow the lower jaw to fully drop down and back to bring the chin to the throat. Monitor this full jaw opening in a mirror to make sure the opening is straight. Repeat 6 times a day. Progression. Perform with tongue dropped off the roof of the mouth. And mandibular stabilization exercises. Maintaining the jaw in a neutral position. Apply gentle pressure to the jaw using your index finger or thumb bone. Hold for 2 seconds. Repeat 5 times a day. And mandibular stabilization exercises, advanced exercises. Place knuckle of index finger between top and bottom teeth. Remove it, keeping the teeth separated 1 knuckle apart. Apply gentle pressure to the jaw using your index finger or thumb, as demonstrated in the pictures above and below. And cervical retraction, chin tucks, standing or sitting with shoulders back and chest up. Bring your chin straight back, creating a double chin. Do not allow your head to bend up or down as you do this. Hold for 2 to 3 seconds and repeat 10 times. Neck stretches. If these are required, your physiotherapist will provide you with an additional exercise sheet. Results. In studies based on physiotherapy treatment, manual therapy was found that the age of the participants ranged from 14 to 83 years old. Most studies involve groups with less than 25 participants, including both genders. Only in one article, the subjects of the study were only women. In terms of treatments tested, most studies have investigated the effects of manual therapy and/or massage combined with other techniques, such as the use of occlusal clefts, resulting in improving the symptoms of temporomandibular disorder. Studies evaluated the patients before and after treatment in terms of pain and mandibular function. Studies have not assessed the long-term effects or maintenance of the results obtained. Reducing pain and improving mandibular mobility is the main achievement of studies in this field. Not being a focus of physiotherapy, there is a few reference to recovery of orofacial function. Regarding the effect of techniques used in physiotherapy, the combination of orofacial treatment and other traditional therapeutic modalities such as manual therapy, ultrasound, and laser therapy, showed better results, contributing to the reduction of orofacial pain and mandibular function. In addition, the use of a device that assists in the passive movement of the mandible gives functional improvement in a shorter time than conventional therapy. Laser therapy alone does not show significant result. Clinical case studies involving participants of both sexes showed the effects of the following treatments on temporomandibular joint. Myofunctional therapy, global pastoral reduction, occlusal adjustment using a combined orthopedic apparatus, electrostimulation, orthodontic treatment, manual therapy. In all studies, treatments provided an improvement in the signs and symptoms of temporomandibular disorder. Overall, in all areas of healthcare included in this review, we observed a lack of consensus regarding the protocol of treatment and the use of equipment and devices for therapy. EMG was the most common method of complementary assessment. Although the main focus of the studies is to improve the patient's quality of life, only 2 articles addressed this topic, and only one of them used the protocol of quality of life to control the effects of approved treatment. Among the underlying disorders included in the study, myofascial pain was the most prominent symptom, followed by articular disc degeneration and degenerative inflammatory disorders. All that mentioned above confirming the findings of Manfrendi. According to these authors, muscular disorder is the most common sign in patients with temporomandibular disorder, followed by displacement of the articular disc and degenerative inflammatory disorders. Clinical studies which used control groups presented more detailed methodologies. This fact would allow the study to be repeated and verify the reproducibility of the results. In terms of treatment outcomes, most treatments prioritize reducing pain and improving mandibular mobility. Few studies examine changes related to orofacial function. Only the speech therapy resulted in rehabilitation of both orofacial functions and orofacial myofunctional balance. Conclusion. Despite the growing number of studies on temporomandibular disorder treatments, there is still no consensus on the best therapy. Speech therapy focuses not only in reducing pain, but also in rehabilitation of orofacial functions. There was a great variety in the treatment protocols used, each of them resulting in an improvement of patient situation. However, protocols that combine different techniques, such as orofacial myofunctional exercises, combined with laser therapy or the use of an occlusal left, combined with orofacial myofunctional exercises, demonstrated better results than isolated treatments. Laser therapy alone does not give better results than full myofunctional treatment. The combination of these therapies promoted improvements in mandibular mobility and reduction in orofacial pain. Here are the reference. You find the attachments here. So this was my presentation. As I said, at the beginning, I hope very much that you found this presentation very helpful and interesting, and feel free to email me for any further information. I'd like to thank you and wish good luck for every one of you. Goodbye.
This was the presentation from Dr. Irina Kola. Please let me know if you have any questions regarding these topics so that we can send to concerned speaker if you have any questions. Any questions regarding this topic? Yes. Thank you so much, madam, for participating in this event. On behalf of organizing committee members of Physiotherapy 2021, we want to thank you for this presentation. Looking forward to meet again next time in physical event in 2022, if everything goes well. If you have any questions or comments, you can text here so that we can ask behalf of the participants. Yes. Next we will be inviting Dr. Mays Al Jawari from Sheikh Shagbot Medical City from UAE. The topic will be physical therapy role in emergency department during COVID-19 pandemic. Yes, madam, you can go ahead by sharing your slides. It's fine.
Hello, shall I start now?
Yes.
Can you hear me well?
Yes, madam, you can go ahead.
All right, thank you. Hello, everyone. My name is Mais Jawhari. I'm a senior physical therapist in Sheikh Shakhbout Medical City in UAE and Abu Dhabi. I am very honored to be a participant in this conference, and thank you for the invitation. So today my presentation is about physical therapy role in emergency department during COVID-19 pandemic. Right. So actually, this presentation is just one moment. Yeah, this presentation represents the beginning of the pandemic. So we all now know that almost everything changed, and we almost went back to our normal lives. But this is at the beginning of the pandemic in 2020. So this might be a little bit like maybe we have a few answers now, but I will be talking about the time of the beginning of the pandemic. So what we still don't know about COVID-19, it's not a simple viral pneumonia. Why? We used to see patients with silent hypoxia or happy hypoxia, which means that their SpO2 saturation reaches 80s or 70s, and the patient is looking very well. So this was one of the most dangerous features or signs or symptoms for COVID-19 that we don't understand. COVID-19 also, it can push kidneys into failure, and not only kidneys, it can reach to the brain, it can facilitate a stroke, it can reach to the heart, and it can cause multiple systems failure. And that's why COVID-19 is dangerous. It can send the body's immune system into a catastrophic override. And this was one of the main reasons why some patients will need, for example, intubation, or they will need to stay in ICU while others won't need it. So what was the physical therapist role in emergency department? At that time, our hospital, Sheikh Shakhbout Medical City, tend to be a COVID-19 hospital. So we didn't shut down, of course, like that. We in OPD, we used to see patients with a priority one, like post-op or stroke patients, also in inpatient and the wards, but all over the whole hospital turned to be taking care of COVID-19 patients, especially with the surges. So the physical therapist's role in emergency department was helping in triaging and assessing 30 to 45 patients per day, assessing them, like taking the vital signs, the blood pressure, the temperature, checking the heart rate, the SpO2, especially when they, for example, they will the triaging system was in 3 stages, but when the patient reaches the stage where they need a medical attention, the physical therapist was there to help and to check the eligibility of active or self proning. So why we prone COVID-19 patients? I'm sure that you heard about the passive proning or proning in ICUs, and already this is a very old method, especially in the acute respiratory distress syndrome, ARDS. And there is a very big, well-known study about the proning patients in ARDS. So the COVID-19 patients, they presents with something similar to the ARDS, but not very typical, which make it more complicated and difficult to deal with. But we saw that passive proning for patients in ICUs help to increase the SpO2, to decrease the respiratory rate, to decrease the heart rate or normalize it. So why we don't, for example, try to active prone patients or ask them to lie in their stomach while they are, for example, in emergency department, like to start too soon or to start early as the patient in the ER. Why we do that? Because this is will help in recruiting the dorsal lung regions. Patients, when they have acute respiratory distress syndrome, or when they have a viral infection in the lung, or when they have a pneumonia, there will be difficulty in recruiting the dorsal regions of the lung. When the patient will lie in their stomach or when they will be in prone position, this will help them to recruit the dorsal regions of the lung. Also, it will increase the end expiratory lung volume. So this will help again to recruit more alveoli, to increase the SpO2, to decrease the respiratory rate, increasing the chest wall elastin, decreasing the alveolar shunt, and improving the tidal volume. What are the factors contributing to effective proning? First of all is the correct patient selection. And we will be talking about the inclusion criteria. So for example, patient should be alert, awake, can communicate. They can turn back into supine position if, for example, the prone position was really they were in distress in the prone position. Timely initiation. When we start soon, this means that we will have a better outcome. And duration of patients' placements in this position. For how long? This was one of the questions that most of the clinicians ask. So for example, when you put the patient in a prone position, for how long the patient will stay? Actually, there is no a right or wrong answer, as much as the patient can stay in this position So the patient will have more benefits from staying in this position. What are the benefits of proning? Again, as I mentioned, improve the oxygenation, prevent the need for intubation, decrease mortality. For prevent the need for intubation, actually there are no studies to support this. Actually, it might be like proning the patient, it might delay the intubation when it's really needed for certain patients, but we did not use the active self-proning in emergency department as a method of saving, for example, the patient life, or if, for example, the ER physicians saw that the patient need the intubation, then the intubation will be done. We didn't use it as a part of, for example, not intubating the patient. So for prevent the need for intubation and decrease mortality, we have a lot of questions about that because there are no studies to support this. What are the risks of proning? The risk of proning, the only risk is delay intubation. SSMC active prone protocol, Sheikh Shakhbout Medical City active prone protocol, all suspected and confirmed COVID-19 patients who met the following criteria. FiO2 more than or equal to 28%, which means that the patient needs to be in a 2-liter nasal cannula or requiring basic respiratory support to achieve SaO2 92 to 96%. Consider prone position if the patient is able to communicate and cooperate with the procedure, if the patient is able to rotate to front and adjust position independently. We need to monitor the oxygen saturation for 15 minutes at least. Continue proning process if nil, obvious distress. Discontinue if the respiratory rate is more or equal than 35. If the patient looks tired, if the patient started to using accessory respiratory muscles. The SSMC retrospective report, 60 patients proned in emergency department during May 2020, 20 patients selected randomly, and I will be presenting their data now. All met inclusion criteria for active proning, confirmed and suspected COVID-19 cases, presents with hypoxia requiring basic oxygen support. The audit aims to show the difference between baseline SpO2 and post-proning. Regarding the age, average age was 41.3. Regarding the gender, all are male patients, and regarding the work, all are laborers. Regarding the nationality, 32% were Indian, 32% also Pakistani, 21% Bangladeshi, and we had 1 Jordanian, 1 Filipino, and 1 Nepalese patient. The oxygen support, 27% were in 2-liter nasal cannula, 21% in 4-liter nasal cannula, 21% in 5-liter nasal cannula, 11% in room air, then 5% in 7-liter, and 5% in non-breathing mask and 15 liters, and 5% in 15-liter nasal cannula. For this table, the first column is the SpO2 before prone position. The second column is the SpO2 post-prone position. The third column is SpO2 improvement. And the last column is the comorbidities. The patient in red were deceased. The patient in green, like this was the only patient that I was able to follow their treatment from ER to ICU to the ward, then till discharge. And the patient in yellow, this patient, the SpO2 actually decreased after the prone position. So as we see here, for example, for the patient in red, their SpO2 was 85% before proning position, and after proning position, 96%, so 11% improvement, and the comorbidities was DM. This patient was 56 years old man, and unfortunately, he needed the ICU, he needed intubation, and he was in mechanical ventilation, and he deceased at the end. For example, the patient who improved and he discharged, his SpO2 before the prone position was 94%. After the proning position, 98%, the improvement 4%, and he was also diabetic. For the patient who didn't improve, actually, I feel that at the beginning, especially that, for example, physiotherapists don't have a specific training, or anyone actually, to be honest, nursing or physician, a specific training to deal with pandemic. So maybe at the beginning, like the selection of patients was, maybe the selection of this patient was not really right at that time. So the patient was in distress, and he started to use the accessory respiratory muscle. His heart rate and respiratory rate also increased. So he was in distress. So we immediately asked him to be in supine position again. Regarding the result, 15% deceased, 20% intubated, 95% SpO2 improved, 5% the SpO2 didn't improve, 50% of all these patients were with comorbidities, and the other 50% without any comorbidities. What are the report limitations? Active proning in ED improves the SpO2 in the first 5 minutes. The duration of improvement should be investigated. So for next reports, we need to, for example, observe the SpO2 for longer duration, after 15 minutes, after 30 minutes. So it will be a more reliable data. Other parameters like chest X-ray, CT, and initial blood work should be included. So we need to understand the differences between the patient. For example, why some patients, they improved, others they didn't, why some patients needed intubation, why others didn't need. Number of sample is small. I think that's all. Now it's like my references slide, but it's stuck. I'm happy to answer any questions. Thank you.
Yes. Any questions regarding this topic to Dr. Mahesh Jawari? I would like to inform Dr. Mahesh Jawari is joining the scientific event since last 3 years. Even we have completed 2 conferences during pandemic period. We have got so yes madam, you can see in chat box from Dr. Baranko. Do you use shock wave therapy for temporomandibular pathology? I think this question is for Dr. Irina or yourself. You can see in chat box. Hello.
This question for my colleague.
This is the question to your colleague. Yes. Yes. Yes, thank you so much, madam, for joining in this event. Thanks for sharing your tips and topic in front of this. Thanks for looking forward to meet the next event.
Thank you so much. I'm honored.
Yes, please with your topic. Looking forward to meet again next time. Yes. Next, the keynote presentation from Dr. Silvio Dirocco, MPR International School for Switzerland. The topic will be myofunctional posterior rehabilitation interdisciplinary protocol negative effect on the craniofacial system in sport BED body equilibrium device to avoid it. Yes, sir, go ahead by sharing your slide.
Hello, sir. Can you hear me? Yes. Can you hear me well? Yes.
Yes.
That's okay. Okay. Thank you so much. I will start my presentation now. Thank you for your invitation again. I am very happy to participate in your meetings every time. It's very nice for me to participate. It's a very nice event, and I am very, very happy to stay there with you. Okay, I will try to open my camera and we will start the presentation. If you like, I can share my PowerPoint. All right. Okay. Let me share the PowerPoint, and I will start in a minute. Okay. Okay, the presentation of today, as you're talking before, is regarding the sport performance. And I would like to introduce before the whole protocol, because as you know, the MPR is myofunctional and postural rehabilitation, where we are dealing with the balance of the whole body. And in sport therapy, that is very, very important. If you have a good balance in the whole body, performance of a sportive is better. And in our protocol is a new approach in physical rehabilitation, but also we apply the MPR, just not in dysfunctional patients only, but also in sportive. And the topic of today is that. MPR is, as I told you before, is in myofunctional and postural rehabilitation. And I will try to introduce a little bit what is the concept of MPR, because if I can do that, you will understand why the performance can be improved in the sportive people. Our school is a school who is all around the world, also in India, in America, in Europe, and the whole world. We teach for all medical sciences this new approach, just not for physio. We teach for medical doctors, dentists, physiotherapists, osteopaths, for all medical science to work together with the same protocol. And that is MPR. MPR is, this topic is focused in a device that we use in our protocol, that his name is BED, Body Equilibrium Device, and how we can improve the sport performance. It's very well known all around the world that the craniofacial dysfunction is creating a lot of problem in our body. That's why in our school we said balance between craniofacial system and tonic postural system. That means the rest of the body. Anytime the craniofacial system is dysfunctional, is affecting our muscle change and our body. What is MPR? Before I start to see the effect in the sportive, what is MPR? MPR is a method who the goal of the method is to put in balance the craniofacial system and the rest of the body. When we have this balance, our body is working well and is healthy. And that is a thing that all around the world, people do not understand, even dentists, because we talk about TMJs. TMJs is a joint who is part of a craniofacial system. It is not a joint, separated joint. And that is an error to treat only TMJs. That's why we said we treat an holistic system. But just a little stop to explain that we have to understand very well craniofacial system, the function and the dysfunction. When this system, in our school, we call that system craniomandibular and cervical and postural system, because it's dealing with the posture that is not only locally, and it's altering the posture of our body. And I think, and I believe, because I teach that in my school, for all people, all physios, all osteopaths all around the world, that it's very important that if all of us understand that concept, because we can work together, we can improve our treatments, and we can help a lot of the patient. But what is MPR? MPR is a diagnostic and therapeutic method. It's not a technique that use tools of different disciplines. And the purpose, it is obtain the balance between craniofacial system and tonic postural system. The objective is to do a holistic diagnosis and to find the priority of the problem. The priority in our school, we means the system or the things who are disturbing more the body. It is not the cause directly, because in the dysfunction, we have multiple causes, just not one. But all this aggression in our body is disturbing our muscle change and our tonic postural system. And that's why we said we found the main aggressor. And in our experience, 95% is craniofacial system. We talk about integration, neurophysiological integration. Our body is connected. We cannot treat it separately. Integration, neurophysiological systems integration. We said in our school and in our method that any technique that does the integration a traumatic is welcome in MPR. Another thing, the key is that we cannot do everything alone or with an instrument or with one specialty only. We have to work integrated in an interdisciplinary protocol of action, interdisciplinary protocol of diagnosis. And for that, we have to understand each other. It is impossible to work together if we do not understand, if we do not speak the same language in diagnosis and therapy. Speak the same language between everyone, between every health disciplines. We cannot work together, the physiotherapist with the dentist with the doctor, both with an osteopath, if we don't understand each other, if we don't have the same language. Speak the same language between any health disciplines. That is our main point. And I will show you some dysfunction of patients. If you look at the patient, it looks, I show you just to understand why it's important for the athletes, the things I will tell you later. That is it as a man who has a shorter leg. It looks like this. But if you put the two cotton rods between the teeth, the arms is growing. And we said that is magic. No. With the cotton rod, we are annulating immediately the negative effect of the craniofacial systems into the muscle chains. Relax, no contraction, arms is growing. It's not magic. And that's happened in 3 seconds. Patients like this with different pathologies that we imagine to treat only one specialty. It is impossible. You know? And the same here. Patients with different pathologies, even with a real short leg, it is impossible to treat it only one specialty. And also here, patient with oculomotor system disturb, craniofacial system problem, posture, it is impossible to treat. Even here, look at the patient was operated a lot because the surgeon was looking only at the pain. It's starting to operate in the lumbars, the pain carry on, and then slowly do the operation of the whole colon. That's terrible because he looked the patient through the eyes of his specialty. That's very wrong in medical sciences. And I can show you a lot of patients like this, a lot. Young patients, elderly patients, all of them have the same pattern. And if we do not understand that we have to work together and we have to speak the same language and to see the patient with the same diagnosis, we never will treat this patient permanently. We only treat the symptoms. And I think that is a problem in the whole medicine. All these patients, and I can show you thousands and thousands of patients with this problem, the same, who were to the dentist first, then to the osteopath, to the physio, and they never communicate. And they never work together with the same protocol, with the same point of view, and the patient is chronic. That pattern I showed you is 1936. Professor Muzzi, who was an Italian dentist many, many years ago, he was the dentist of the king when we in Italy had a king 2 centuries ago. And he was talking about the connection of the jaw position and the posture. He published in 1936 in his book this picture. It was studied many, many years before that. It's a long topic that we know that exists, but we never take care of it. Look at that. Forward position, postural alternation. And for the body balance, we have to have a triangular balance. Mind, that means psyches, structure, and biochemistry. If we have imbalance, if we have a balance between all these things, body is healthy. Imagine if we can treat only one part of the body with one specialty. That is impossible because we are only doing symptomatic treatment, not we are curing the patient. And that's why it was born interdisciplinary protocol and the MPR. Interdisciplinary protocol is an integrated protocol. And we said that it's an active protocol because it's adapting to the evolution of the patient. It is integrated because any specialist intervene with the same diagnosis and therapeutic approach. And it's interdisciplinary because whole medical science disciplines are working on it. And the tool of this protocol is the MPR, the myofunctional postural rehabilitation. It is a myofunctional rehabilitation because it's doing a physiological neuromusculoskeletal balance. It is postural because it's doing the rehabilitation of the craniofacial system with the rest of the body. And it is a rehabilitation because rebalance the whole systems of the body. The triangle, mind, structure, and biochemistry. Saying that, I will show you how the craniofacial system affects the rest of the body through the negative effect into the muscle chains. Craniofacial system muscles, they are part of the muscle chains. The dysfunctions in the systems alter the muscle chains, creating hyperactivity mainly, but also hypoactivity. And chronically is creating a muscle chain dysfunction. Mainly, that happens when we lose the jaw position. Nothing to do with the teeth. Normally we see the teeth. The teeth are blocking a right or wrong position of the jaw. Obviously, they close and block it. But the cause of the problem, it is the jaw position. When the jaw position, it is not centrated, and the dental occlusion, that means the teeth are blocking. That situation is creating trouble, is increasing the pressure into the temporomandibular joints, and the temporomandibular joints, it doesn't accept to increase the pressure. And at that moment, it's starting a proprioception defense, very bad defense, because it's sending the alarm to the central nervous system and it's starting the Brooks systems to defend. And the Brooks system is a chaos. It's creating a domino effect. Chronically, it's creating hyperactivity, blocking of the cranial sutures, blocking of the craniosacral breathing, hyperactivity in the muscle chains. Slowly, it's creating a disaster. And it's making worse of the situation because it's abrading the teeth, increasing the jaw pressure, and it's impossible to treat it only with massage, only with physiotherapy, only with laser. No, you have to centrate the jaw. You have to put the jaw centrated, and you have to put the teeth in the right place. And then all the therapies are working. But to do that, you have to annulate the system before. You cannot treat the craniofacial system immediately. And that is the effect of bed. I will show you later. And that's why it's improving the performance in athletes. With bed, body equilibrium device, we are eliminating the bad effect of the craniofacial system into the whole body. Then we can treat it. Then we can do anything. But if we annulate, the job is done. Look at that, lateral deviation. And if you see here, 4 kilos, when the mouth is open, patient close the mouth, and it's increasing the overload to 9 kilos. Anytime the jaw is in that position, it's increasing the body weight. And that's why the central nervous system say, joint is under stress. Body is under stress. My only defense, immediately defense I have is bruxisms. And it's a very bad defense. The back position of the jaw is the most dangerous situation. Lateral deviation is bad, forward position is bad, but the bad situation is the lower position, and when the patient loses the vertical dimension, the height of the lower part of our face, that is creating a lot of problem in our muscles. It's creating compression in the most important area of the temporomandibular joint, the back area, where it's arriving the whole alimentation, innervation of the joint. We cannot invade that area. If the pressure is increasing there, it's a catastrophe. And generally, it's creating that situation with the blue system, it's creating hyperactivity, a block. Sutures, and fascial sutures is creating hyperactivity there. It's creating hyperactivity in the suboccipitals, and it's blocking the cervical column first. And then slowly, it's going down. It's going down, the hyperactivity is going down from there, trapezius, grand dorsal. We are going slowly to the grand dorsal, descending, is creating their hyperactivity. Some problems in that joints is related with the craniofacial system dysfunction. Because our body is connected, and then it's slowly going down. It's creating trigger points. It's creating a lot of problems, creating adaptive scoliosis, and then chronic disease. In the atlas, I did that introduction just to you understand that diagonally now. Atlas is the same, but it's worth, because Atlas is a perfect machine. Imagine if you compare a Ferrari with Fiat 500, two machines. With the Fiat 500, you cannot change the oil frequently. You can do the service when you like, when you have money and the car is going. The Ferrari, if you don't do the service that the company says, you've broken the car and the car is not working. Atlas is a Ferrari and have to have a perfect balance in the whole body to increase the performance. We have no time here to explain the effect of the oculomotor system. It's very long, but concentrated now to the craniofacial system dysfunction. If these athletes do not have a good function into the craniofacial system, they can create a lot of problems. Look at that. This is a research I did. Athletes with jaw position disturbing, who is creating, as you see here, instability in the posture and overload. And I try to prove what happened with the performance if we just annulate the craniofacial system. And we do that. We do that with beds. Improving that was immediately, it was after, obviously, it's not a treatment, it was a research that to demonstrate if we annulate the system, what happened with the patient, with the athlete. After the programming, improved the body weight and the oscillation of the body at barycenter was centrated. And then, with the bed, it's a thermoplastic device to adapt into the mouth of the athlete. We do exercises without bed and with the bed. With that athlete, we do these exercises. Here the athlete had the bed, you see there, into the mouth. And after correction, they increase 25%. More forces. How we do that? We starting to say to her, do forces when you cannot do more. you stop. All right? No relaxing, because if relax, and you improve the muscles, we put immediately the device, walk in 3 steps, carry onto the machine, and do the exercise again and improve 25% kilos more forces. That's another one with craniofacial dysfunction, postural alteration, and also their oculomotor system and chair. We put the bed device, we improve, and we see that the posture improve, and then we go to the exercise. That's the correction. And with these athletes, also with bed, that was the exercises he did. And on the same, we said to him, here is with the bed, you see? We said to him, you do the exercises without bed. When you don't have more forces, stop, put the bed in the mouse, 3 steps, go again. And also him, 25% of more forces. That demonstrates that if you annulate, if you put the whole body in balance, performance improves. But a big disturber of the posture is craniofacial system. If you annulate that, today it's very common to see athletes going with the mouse guard in the mouse. But if you annulate that, if you put the body balance in harmony, increase the performance. And let me show something of some athletes. Injuries also. When we have the body not in balance, we have a lot of injuries. And also here, craniofacial system is a very big problem. Look at that. This is a machine. He was like this before. Look at the eyes here. The hypoconvergence related with the jaw position. I cannot explain here what is the mechanisms in a short time, no? But look at that, jaw position deviated. Occlusal plane, who is creating a lateral deviation of the jaw. Inclination of the head, adapting. Correction. Occlusal plane is very good. Straight the head. And perfect body. That's another one who has no problem. Federer. And we compare Federer with Nadal. Federer have a very good balance, good convergence. You see there. Good occlusal plane, less injuries. Nadal, convergence is not good. Occlusal plane is not good. Always have an injury. Athletes with a lot of injuries, with the craniofacial system, know very well. Ronaldinho. Also Ronaldo, the mouse, the craniofacial system, the eyes, the muscle change, injuries. That was a perfect machine, Pelé, with a very, very good body balance. In that presentation, thank you so much for your time. In that presentation, I tried to explain in a very, very short time how, if the body is not in balance for the athletes, the performance is less. And how into this unbalance, the craniofacial system is one of the main disturbers of the body. if you want to go to our channel, we have a channel with a lot of video. There you can see a lot of video there. You can subscribe; it's free. And this is our contact if you want to contact us. Thank you so much for your attention and for your invitation. I am very happy anytime I am here with you. Thank you so much. If there's any question, I am here.
Yes, any questions? If you have any questions, you can text in chat box. We'll be asking behalf of you, even after the completion of the conference. Any questions? This was the keynote presentation from Dr. Silvia Di Rocco. Sir, I think there is no questions.
Okay, thank you so much, sir, for your invitation, and I hope I will see you in the next event in your company. Thank you so much. Thank you. Bye-bye, everybody.
Yes,
Bye-bye.
yes. Thank you so much, sir. We have enjoyed your speech. Pleased with your topic. Looking forward to meet you again next time in physical event in Dubai in 2022 as one of the keynote speaker for this conference.
I hope we can meet together in Dubai again. I miss Dubai because I've been very many times in Dubai, and with this COVID situation, I cannot. I hope now and the next year we can be there in person. I hope we pray for that. Okay, and and maybe we can meet together in your meeting. Okay, yes. Thank you so much for your invitation, sir. We
can collaborate with your institute, sir.
Thank you so much. Thank you, sir.
Have a nice day, sir. Bye.
Have a nice day to all of you. Thank you.
Next, we ask Dr. Serdian Dilas Harris, Department of Respiratory Medicine and Allergy from Aarhus University Hospital from Denmark. The topic will be tele-rehabilitation program in anti-fibrotic medicated idiopathic pulmonary fibrosis patients. Yes, sir, you can go ahead.
Yes, can I get access to share my screen, please?
Yes, sir, you can in the bottom of the screen you have share screen option.
Yeah, it says host disable participant screen sharing. So you have to give me the option to see it.
Yes, no. Yes, you can go ahead.
Okay. Good. Here I share my screen. Can you see my screen? Can you see my screen?
Yes, sir, you can go ahead.
Great. Thank you for this opportunity to participate in your Congress. As you said before, my name is Jose Ferran, a PhD student from Aarhus University Hospital in Denmark. And today I'm going to present one of my studies that is based on telerehabilitation of patients suffering for idiopathic pulmonary fibrosis. Especially this study, or this part of the study, is going deeper in some statistics we did that we have not published yet. So we have already an article that you can for sure read, but here we go a little bit deeper in some parts that I will explain later. So regarding idiopathic pulmonary fibrosis, it's a rare disease, and the challenge that patients suffer with this diagnosis is that as soon as they get this, their life expectancy is reduced to 3 to 5 years. So meaning that it's not one of the kind ones. We understand that this patient group, if they get pulmonary rehabilitation, they can improve their exercise capacity and quality of life. But our challenge in Denmark is that because it's a rare disease, this patient group is scattered in big geographical areas. And because there are not so many of them, we cannot put them together in a training setup that they can come 2-3 times every week to train with us. So we have patients in our hospital that are going from 100 to 200 kilometers away, and this is not going to happen to meet them 2-3 times every week. So we were thinking that using telerehabilitation, potentially we can reach all of them. And this is for this study. So our aim was to investigate if the usefulness and efficacy of telerehabilitation in patients suffering from this disease based on exercise capacity, quality of life, and this is what I will present. So we did a single center prospective and randomized study where we enroll stable IPF patients that were able to, in the intervention group, were able to participate in a 3-month telerehabilitation where they had the opportunity to meet physiotherapists in video consultations, but then also train with our virtual autonomous physiotherapist agent, meaning it's an agent that is like a clone of a physiotherapist that is treating the patient at home autonomously. I will show some information later about that. Then we have the control group that we just were following as also the intervention group. They were coming every 3 months to the hospital all together, but this group was not getting any telerehabilitation because there is nothing in Denmark today for them. We were following different parameters. The first one was the exercise capacity, where we used the 6-minute walk test. It's just a test where the patient is walking during 6 minutes, and we are enumerating the steps, the meters they are walking, but also we follow the oximetry and see if there is some change on that. Then we have some questionnaires on quality of life that are very focused on patient groups with lung chronic disease, as the King's Brief interstitial lung disease and the St. George respiratory questionnaire. And on top of that, we have an anxiety questionnaire named GAD-7. We also follow the lung functions to see, we understand that in this patient group, the lung functions used to go decrease from they get their diagnosis. And here was the forced vital capacity and the DLCO that resume is the diffusion of oxygen in the blood. So it means how well the patient can extract oxygen from the air and put this in the blood vessels. In the intervention group, the group that was getting telerehabilitation, we follow as well the adherence, the patient satisfaction, and if it was safety. We did everything. We took measurements in baseline after 3, 6, and 9 months. So the results, well, come later, but just so you understand how it works with this telerehabilitation platform. Me as a physiotherapist, I had access to a software as a service, a web app, and there I was able to create different training programs with exercise sets, with e-learning, and with questionnaires. And with that, I was able just to follow my patient and see how well they were performing at home. The patient on each side has the opportunity to get an app installing a smartphone or tablets. All our patients were getting free tablets from the hospital that were connected to a brochure sensor that is just a biometric sensor measuring the pulse of the patient when they were training. This agent was really clever in the sense that was getting information from this sensor and adapting in real time the exercise set to the patient. So here I was able to decide what kind of exercise I wanted the patient to do. I was able to decide the intensity the patient to go through. And then if the intensity start is very low there and finish high in the exercise set, or if it was able to go up in the middle and so on. We were just using the one that patients were starting with easy exercises and finishing with very high intensity exercises. But our agent was clever enough to understand that if the patient started to get breathless and was on the way to stop exercising, then the agent decided to choose another exercise that was a bit easier. But always keeping in mind that we should start with easy exercises and end with high intensity exercises. We were asking how breathless they were before and after the exercises, and in this sense we were able to see if the patient was having some change in their body. So we were able to find another exercise that was in a higher intensity for the next time we met the patient again. So this is the way it worked. The results were interesting. For the first, we had more male in the telerehabilitation with this virtual autonomous physiotherapist agent than in the control. In the age, we had a bit older people in the control as well, but the rest of things were very similar. So in 6-minute walk test, we saw that patients, they were equal in the sense that there was no p-values that were different. But as soon as we come to the 3 months follow-up, here we were able to see that a difference of 40 meters with a p-value of 0.03, meaning that the difference between these two groups was existing. And the same happened after 6 months. Still, patients had a difference in the 6-minute walk test of 34.3. We found as well that in 9 months there were a big difference, but the p-values were not enough to say that it was a difference. So this is what I wanted to show in this Congress, because we have not published this in this article, the telerehabilitation program in idiopathic pulmonary fibrosis, where we were talking most about this area. So now we go in a deeper research on what happened there, because we thought why we did not get this good p-value. And in our deeper research, we found that if we go to the control group, all the patients were treated with one antifibrotic medicine named OFEV. And in our intervention group, the patients that were getting telerehabilitation, we had patients taking the same medicine, some other taking another one that is the same equal medicine in the same, both are antifibrotic. But we had also 3 patients here that were not taking any medicine. And this is because normally medicines are good, but sometimes they have some B effects that some patients are not able to use, in the sense that the medicine is giving something bad that is not possible for them to take the medicine. So we decided to divide these 2 groups in 3. We had one that was training and taking antifibrotics, one that was just taking antifibrotics, and one that was just training. And as you can see, the training group was scoring very low according to the other ones. So we decided to take them out from the statistics and see what happened. Suddenly, again, in the baseline, we had a very normal p-value, so patients were equal. But in 3 months, if you remember, we had around 40 meters here in this gap. Suddenly, it was 96 meters. And in 6 months, we had 104 meters when it was 34. And in 9 months, where we had 40 before, suddenly we had 150 meters. And all of them had a really good p-value, meaning that there was a difference between them. So this is what I wanted to show today in this Congress that I think is interesting to think about. most in respects to this other study that is written by Dubois, where they arrive to the conclusion that patients with IPF reaching this critical mortality indicator, 250 meters, means that they were very close to die, is in these 250 meters. So if we think about our two lines, the patients training and taking antifibrotics and the patients just taking antifibrotics, if we follow these two lines, I think that the patients training and taking antifibrotics potentially will have a longer life expectancy than the other ones. So I think this was interesting to show, and this is what I come with. Regarding the rest of parameters that we were following that are published in our article already, we were not able to see any difference between the quality of life in the St. George questionnaire and the Coville questionnaire, neither in the CAT-7, even though you can see some difference, there were not a statistical difference there. Neither in the forced vital capacity and the LCO, patients were decreasing almost in the same way, even though you cannot see even though you can see some difference here, the p-values were never positive to say there was some difference in groups. Regarding the adherence in the patient group that was training, maybe I forgot to say it before, we have 15 patients that were in the intervention group. Of those, 5 patients decide to continue training after the 3 first months. And of those 5, 3 patients decided to continue after 6 months. But just in this period, patients were having a meeting with physiotherapists online, different meetings. Here there were no meetings. Patients that were just training with the VAPA, the Virtual Autonomous Physiotherapy Session. So we were expecting them to train together 720 minutes, and they trained 463 minutes, meaning that their adherence was 64%. For the patients that continued training, their adherence increased above what we were expecting, and after 3 months more, the 3 patients that were left there, they trained even more. So it means that just training with VAPA makes the patients to train more. And we can see as well in the exercise set, this is the time they were training for each exercise set, the mean time. So in the first period, from 0 to 3 months, they had an average of 16.5 minutes. After 3 months more, they started to train more in the exercise set, and after 3 months, even more. This is just the time they train, so without the pause in between the exercises in the exercise set, meaning that in an exercise set, you have exercises and pause, exercise and pause. So this is just the time they were training the whole time without what we take out all the time they had pauses. What more? So we were not able to see any adverse events. So it means that is safety somehow. And our conclusions are within telerehabilitation with this virtual autonomous physiotherapy session is useful for these idiopathic pulmonary fibrosis patients. That exercise capacity was maintained at 3 and 6 months for patients that both patients that were having medicine and not, but it was also maintained at 9 months for the patients that were just taking antifibrotic medicated, At the same time, we saw a remarkable decrease with patients that were just taking medicine and not training at all in the control group. Telerehabilitation, we think, can potentially prolong the life expectancy of this patient group. You have to understand that we don't have enough patients, but potentially if we do a bigger study, we can, on a longer perspective, we potentially will be able to show that patients training and taking antifibrotic medicine will have a longer life expectancy. So we hope that some researchers wants to do this study as well, together with us, if possible. Then there were no changes in quality of life or anxiety, and we understand that it's relatively high adherence using this platform, as well as high patient satisfaction and safety for the users of this platform. This is everything from my side. You have a QR code where you can get in contact with me using your smartphone. And you are always welcome to contact me if you have any questions regarding my study and my other studies that are about there are some other lung disease we are working with on this area. Thank you very much for being able to participate.
Yes, this was the presentation from Dr. Joe Sedan. Any questions on this study? What was delivered by Dr. Joe Sedan? I think there is no question, sir.
Okay, understood.
Yes.
Thank you for.
Yes, thank you so much, sir. We have enjoyed your speech. Pleased with the topic. Looking forward to meet again next time in physical event in 20.
Okay. Could be really interesting to be there.
Have a nice day, sir. Bye.
Bye.
Next, we do have more. 1, 2, 3, 4, 5, 6, 7. We do have 8 more talks for end of this today's session. That will be Dr. Edano Sapaji, Dr. Julia Ramal, Dr. Somya Prasad, Dr. Kavita Bakshi, Dr. Syed Wahid, Dr. Soman Saleh. So next we ask Dr. Edonos Sopaj, Radiology Department, University of Medicine from Albania. The topic will be MRI diagnosis of disc herniation and rehabilitation. This is the second talk from Dr. Edano.
Hello. Today I would like to present a video webinar on MRI diagnosis, paraneoplastic, trigeminal neuropathy, and rehabilitation. In the beginning, we have some introduction words about trigeminal neuralgia. Trigeminal neuralgia, or TIG-Dalarex, corresponds to a clinical manifestation of sudden severe paroxysm of excruciating pain on one side of the face, which usually lasts a few seconds to a few minutes, involving one or more branches of the trigeminal nerve. The most prevalent cause of trigeminal nerve is vascular compression. Other causes include compression due to cerebellopontine angle, that can be tumor or cysts, perineural tumor spread, or multiple sclerosis. Here we can talk about the importance of MRI in trigeminal nerve. Prior to MRI, the trigeminal nerve could not be well visualized. In nowadays, with specific MRI sequences, we can see trigeminal nerve from 3 different angles. MRI can also help us to determine if there is a vascular compression syndrome. Here we have a head CT scan, but head CT scan is not useful in these cases because CT doesn't have a resolution to show us in details the anatomy of the trigeminal nerve. MRI is very important in identifying and showing the anatomy of the trigeminal nerve. In MRI, we have 2 best sequences.
Yes.
That,
Please apologize. We are sharing yesterday's talk, so please we'll be going to share other talk. Actually, the topic will be MRI diagnosis of disc herniation and rehabilitation. So this was the presentation. Please apologize from our side. Yes, this is the presentation. Just to
Hello everyone. Today I would like to present a video webinar of MRI diagnosis of disc herniation and rehabilitation. This presentation focuses on the role of MRI in the diagnosis of disc herniation. We will also discuss in details about recommended MRI protocol for disc herniation. Then we will also talk about how to distinguish disc herniation from other pathologies that can imitate disc hernias, especially in some sequences or planes when reading on MRI. And we will also talk about rehabilitation of disc herniation. Let's talk shortly about the term disc herniation. Term disc herniation means displacement of disc material like nucleus pulposus, parts of the annulus fibrosus, and cartilage beyond the limits of the intervertebral disc space. Disc herniation can be divided into groups in a variety of ways. Commonly, they are divided into protrusion versus extrusion. Protrusion. Protrusion indicates the distance between the edges of the disc herniation is less than the distance between the edges of the base. On the other hand, extrusion is present when the distance between the edges of the disc herniation is greater than the distance between the edges of the base. Extrusion usually is associated with defect in the annulus fibrosus and are usually non-contained. Here we have an illustrated figure about what we talked before, protrusion. Protrusion, here the edges of herniated disc are smaller than the base, and extrusion, the edges of herniated disc is greater than the edges of the base. Herniations can further be classified as contained. We say contained when they have intact outer fibers of annulus fibrosus and posterior longitudinal ligament, or only with an intact posterior longitudinal ligament. Not contained tier of outer fibers of annulus fibrosus and posterior longitudinal ligament. Migration. Migration is displacement of disc material away from the site of extrusion, regardless of whether sequestrated or not. Sequestration is usually used to indicate that the displaced disc material has lost continuity with the parent disc. Intravertebral herniation, or Schmerl node, is herniation of disc material in the vertical direction through a gap in the vertebral end plate. Here we have a detailed MRI protocol. Let's start. The MRI protocol for examination of the lumbar spine in patients with symptoms of nerve compression is quite simple. Basically, we rely on the sagittal T1 and T2 images of the levels of suspected pathology. We do not have to use a saturation band on the anterior side or a rectangular field of view, because you also want the image of the paravertebral soft tissues, which also are very important. Especially, we have to look for an aneurysm of the abdominal aorta, since this may also be the cause of the low back pain. Sometimes it can be difficult to clinically differentiate neurogenic claudication, which is caused by spinal stenosis, from vascular claudication, which is caused by arterial stenosis. The frequency encoding should be in AP direction and consequently in the phase encoding feed-headed. This has several advantages. The resolution is the highest in the frequency encoded direction. We want the highest resolution in the AP direction to look for small herniation and delineation of nerve roots. Sorry. When you have the phase encoding in the AP direction, you get breathing artifacts. This is why some use a saturation band of the RFOV. With a frequency encoding in the AP direction, you do not have these problems and you do not need a saturation band. Frequency encoding in the feed head direction can result in poor delineation of the vertebral end plates due to chemical shift artifact, when the fat in the vertebral body meets the water in the disc. This is another reason to use a feed head phase encoding and an AP frequency encoding. Interpretation. The sagittal T1 images gives you the most diagnostic information. Before start looking for any hernias, Please, we repeat, take a good look at the paravertebral tissues and bone marrow. Once you have detected any abnormality, correlate these findings with Day-2 images. We have to remember the first study, the sagittal T1, paravertebral soft tissues, bone marrow, 4 levels of compression, and also always we have to correlate the findings of T1 with sagittal T2. Here is a 25-year-old patient who presented with low back pain. Notice multiple small masses in the abdomen, into abdomen surrounding the mesenteric vessels and abnormal low signal intensity of the bone marrow. The signal intensity of the discus is a little bit higher compared to the bone marrow. This examination was the first indication of an abnormality in the patient. This proved to be bone and lymph node metastasis of a carcinoma of the colon. Here another patient with widespread lymphadenopathy in mesenterium and retroperitoneum. Here we have a patient who presented with severe low back pain. We can see aortic dissection with a red arrow. Sometimes these aortic abnormalities are an incidental finding. Here we have a focal protrusion of the L5-C1 level. The C1 nerve is compressed. Here we have showed it with a yellow arrow. The findings at the different levels, 1 to 4. At the level of the disc, there is a minimal spinal canal narrowing by bulging of the disc and facet arthrosis. At this level, there is a cerebrospinal canal stenosis due to bulging disc and facet arthrosis. There is also an annular tear, high signal through which is disc herniation with a yellow arrow. At the level of lateral recess, there is a focal herniation of disc material compressing the L5 nerve. This is the other figure with a yellow arrow. This is called an extrusion because the distance between the edges of the disc material is greater than the distance of the base. Yes. Compressing L5 nerve, blue arrow, within the lateral recess. This herniated disc has migrated caudally and is seen as a novel structure anterior to the nerve. The herniated disc is an uncontained, not covered by fibers of the annulus fibrosus. The sagittal intensity of a hernia on T1 images is usually intermediate, while in T2 images it can be a high signal fresh herniated nucleus pulposus or a somewhat older low signal intensity hernia. Here a herniation with a high signal is showed with a yellow row on transverse images, sliding through the annular tear and compressing the left L5 nerve, blue row. Here are some other diseases that can also give symptoms like disc hernia. This is a differential diagnosis. There can be processes of vertebral bodies like osteophytes and metastasis. There can be from processes from intervertebral disc like discal cyst, from C, intervertebral foramen, which can be any neurinoma, can be D as apophyseal articulation like synovial cyst, and the last one, it can be any lesion in epidural space like epidural hematoma or epidural abscess that also give a clinic like disc herniation. Usual therapeutic scheme for treating the disc hernia, we should always start with first with medical treatment, then we go with physiotherapy, and in case that all this above fails, then we go with an open surgical operation. Clinical evolution of disc hernia. Symptoms often begin with back pain. The mechanism is the compression of the posterior ligament of the disc, reaching nerve endings. Subsequently, a pain in the leg appears according to the compressed nerve root, axial cut of herniated disc. Let's talk about medical treatment, except in case of severe neurological emergency. Medical treatment should always be used first in the face of painful lumbar or lumbar root symptomatology. The classic treatment associating anti-inflammatories, myorelaxants, epidural infiltration, short injections of corticosteroids, and physiotherapeutic help is often effective, but if the result is not obtained quickly, then it should be released to interventional radiology technique that would be the last stage of medical treatment. Let's talk about some intradiscal treatments. We can mention several interventional radiology techniques which have already been proposed. This is intradiscal injection of an enzyme, hemopapain, manual or automated percutaneous nucleotomy, nucleoplasty. There is another treatment with ozone therapy, and we can do intradiscal injection with pure ethanol. Indications. The follow-up of injection radio-opaque gelled ethanol never presented any immediate or late harmful side effects and has a favorable efficiency. Indications should not be limited to contained hernias nor rupture of posterior vertebral ligament. Bulky hernias and excluded hernias are very acceptable indications. Conclusion. In conclusion, we will insist on the main obstacles to the dissemination of the interventional radiology treatments, which are the lack of consideration of the multifactorial and regional nature of the problem, the lack of patient information, and the non-reimbursement of the product. Thank you.
Yes. This was the presentation from Dr. This was the second presentation from Dr. Edeno Sapoge. Any questions regarding this topic? Any questions? Yes. Thank you so much, madam, for participating in this event. Yes, on behalf of organizing committee members of Physiotherapy 2021, I want to thank you for your presentation. Looking forward to meet again next time. You will be getting electronic booklet as well as participation certificate within couple of days after the completion of the conference. So next we ask Dr. Sumaya Zaharin Sheikh from D.Y. Patel School of Physiotherapy from India. The topic will be rehabilitative ultrasonography imaging in the Indian scenario. Yes, madam, you start sharing your slide.
A very good afternoon to everyone. I hope I'm audible.
Yes, madam, it's perfect.
Yes, okay, thank you. Today I will be talking on what is rehabilitative ultrasonography imaging in the Indian scenario, global as well as Indian, but my speciality in the end, I will be concluding on how, what is the final scenario in the Indian context. So for that, first, I will be giving an example. This example, as we know amongst our physio world, is very common, abdominal groin maneuver. The mnemonic or the short form for this is ADIM, or it is also called as the abdominal hollowing maneuver. Though there is a difference between groin and hollowing, the different set of muscles are used. Now, I had a question that how sure are we that only transversus abdominis muscle, that is the innermost muscle, gets targeted or activated specifically during this maneuver which we teach to the patients. We definitely do a subjective evaluation or a subjective confirmation by doing the palpatory test. That is, we palpate a medial and downwards to the ASIS and feel for the tendon using the 2 fingers. But this is still a subjective evaluation. So what about the objectivity? This is how you can see the transversus abdominis contracts, and here is what we feel for the tendon. So objectivity is definitely introduced or achieved using the pressure biofeedback. It can be tested and treated both in supine and prone. We have different measures and the degree of the dial, that is the mm of Hg in supine and prone as well. But how sure are we of this objectivity? Is it still considered to be subjective, or you can call it objective? So a brief about the pressure biofeedback. It is cost effective, easily available, and basically it gives us a simple clinical estimate of who can and who cannot activate the transversus of the abdominis muscle. So while rehabilitating a patient, it is a great medium for visual biofeedback. But the problem here is that it gives us an indirect combined measure. So when we were talking about transversus abdominis, the question was, how sure are we that only transversus abdominis is being targeted? Here, the indirect combined measure is of 4: internal, external, and rectus abdominis. So this combined intra-abdominal pressure is reflected on the dial of the pressure biofeedback unit. So inability, definitely, if the client or an individual is not able to get a particular pressure, so we can say, okay, the transversus abdominis is definitely weak. And it is proven by studies done by Grooms et al., where it has found to be moderately specific. 0.77 is the value. And this transversus abdominis dysfunction should be ruled out which is very difficult to isolate using pressure biofeedback if you are planning for long-term specific rehabilitation plans. So as an assessment tool, the ability, initially we talked about inability. Now, if that client is able to maintain a pressure of 40 mm of Hg, pressure plus or minus 5 mm, it does not imply that the transversus abdominis gets activated. The sensitivity is very poor, that is 0.22, which is very, very poor. It is definitely specific when the patient is unable to do. But ability does not prove, because as I said, there is an indirect combined measure of 4 muscles which are causing the intra-abdominal pressure totally to reflect on the dial. So it is a probable compensation. If the transversus abdominis is dysfunctional, the pressure will prove otherwise. It will mean that it is a false positive test. So the pressure is compensated by 2 muscles which are stronger than the transversus abdominis, and they are the external supports, rectus abdominis and the external abdominis. Now, to get objective, now since we have discussed about PBU, that is the pressure biofeedback unit, the role of transversus abdominis, how do the obliques contribute to the intra-abdominal pressure? So now here comes how do we address this lacuna? This lacuna is, we will see how USG will stand apart from other diagnostic modalities like PBU, which is the most commonly used, in helping us achieve our question. So again, I repeat, does pressure biofeedback unit give us a real picture of the transversus abdominis muscle? Because this is the muscle we physical therapists or we physiotherapists target the most, the core muscle. Okay. So these are the contents of my today's talk. That is ultrasonography imaging. It is also known as rehabilitative ultrasonography imaging, that is RUSI. The timeline, what are the pros and cons of rehabilitative ultrasonography imaging in our physiotherapy world, and how therapists across the world are using it, finally concluding it by addressing the facilitators and barriers in the Indian context. Now, let us imagine or view the muscle in different planes. So here you can see the biceps as well as the triceps muscle on elbow flexion and extension. So on contraction of this muscle, the cross-sectional diameter increases, whereas on relaxation, it will reduce. So this is called as the pistoning effect. And this is what we are going to measure in ultrasonography, the cross-sectional view. So here is the piston, that is when you contract from or when you shorten from both the ends, the cross-sectional diameter of the muscle increases or widens. Whereas when the muscle relaxes, okay, when the piston is let off, the cross-sectional diameter reduces. So here I have actual images or USG ultrasonography images of the same individual in 2 different times. So these are the 3 muscles. The innermost is the transversus abdominis, the internal oblique, and the external oblique. Similarly, here also, it is of the same individual in relaxed phase and in contracted phase of the same 3 muscles. If you can see, they are the nomenclature of 1, 2, and 3. So 1 is transversus, 2 is internal oblique, 3 is external oblique, and 4 is the total lateral abdominal wall thickness. It is in centimeters. So if we compare 1 with 1, it is there is no change. External and internal oblique, they haven't changed when the contraction happened. This means when the abdominal draw-in maneuver was done by the individual, the external and internal oblique, they did not change. What changed was the third reading, that is of the transverse abdominis. 0.2 centimeter, it became 0.37. Here comes the pistoling effect. So the cross-sectional diameter increased. This proves that on doing the abdominal draw-in maneuver, this individual did successfully target the transversus abdominis muscle. Okay, now the second scenario. This is the second scenario. Now both these are my postgraduate students who are physiotherapy postgraduate students who have a thorough knowledge of the anatomy of the abdominal muscles. They already know how to do, and the instructions reinforced their learning and activation. So both of them know what is ADIM. They perfectly understand the anatomy. Now coming to the second situation, the second student, when this is the relaxed phase, this is on contraction, PC is post-contraction. And this is one more chance which I gave to this person to redo the movement. So therefore, there are three scenarios here. So if I see transversus is the lowermost, internal oblique, external oblique. Now here, on doing the abdominal draw-in maneuver, the external oblique readings reduced. Internal oblique from 1.09 centimeters, it became 1.46. Whereas transversus abdominis 0.44 became 0.77. But this in this particular individual, the internal oblique muscle was the muscle which showed the maximum difference change. So both of them were doing the same activation of abdominal draw-in maneuver. The instructions given were same. They both had a thorough knowledge of the anatomy. Yet this person, the second person, failed to activate the transversus abdominis muscle. And there was one more similarity between these two, was that the pressure on the pressure biofeedback unit on the dial was equal, was same. So this means in one person I got a positive result, whereas in the other person I got a positive, but it was a false positive result. So we gave that individual another chance, yet he activated the internal oblique muscle only, 1.64. He failed to activate the transversus abdominis muscle. This means that the obliques, the external as well as the internal oblique, being stronger muscles, they were probably compensating for a dysfunctional transversus abdominis. And this is a very important point to take home, that we have to be aware of these false positive results, because these are the subclinical cases which are often missed, and then they later come to you in a worsened state, in a deranged or dysfunctional state. So coming to the definition, as I have already given many hints about what is rehabilitative ultrasonography imaging. So basically, these procedures are used by physical therapists to evaluate the morphology, the behavior, the architecture of the muscle and the soft tissues. And at the same time, it is giving feedback to the patient. This is very important, visual feedback. So if you see the difference between the visual feedback given by ultrasonography and pressure biofeedback, there is a vast difference, because any layman person is also able to understand it, and it is very much real time. It is dynamic. You can see the contractions happening. You, the therapist, as well as the patient, can see the contraction, the change happening in front of their eyes, once educated, obviously. Obviously, this is a superior form of visual feedback than the pressure biofeedback. And also, it should be viewed as one potential tool, just like a stethoscope. So as soon as you put the stethoscope on the lung field, you can hear the different bronchial sounds and get a clinical picture of what is going inside. Similarly is ultrasonography. So initially, as we know, it was used ultrasonography sound. So sound travels, the velocity of sound was calculated whenever they had to detect icebergs and submarines. So what is the distance coming to the surface? And this is the same principle of ultrasonography. And slowly then it got, the evolution took place over, centuries and millenniums. Yes. So now if we see the pros of ultrasonography versus other diagnostic modalities, that is MRI, CT, EMG, it is definitely more, there are many points, I have highlighted few, cost effective, and it is, the accessibility is less, it is hassle free. I mean, operating an EMG machine or a CT or an MRI is difficult using the console and everything. But USG is just a probe where you apply the gel, aquasonic gel, and you just, the radiologist or the operator should just know where to look for what thing. The exposure to radiation is none compared to MRI. There is no radiation. That is why USG is safe in pregnancy. And there are many other reasons also. And it is, the most important thing is, it is very much real time. It is very much dynamic. You can, you all three, the patient, the therapist, are in sync with what is happening. Yes. So here comes the cons. For every modality has certain pros and cons. So now in the Indian, if I talk about in the Indian context, or even if the Asian context, practical application is a difficulty, because if we see the syllabus or the curriculum of physiotherapy, applicability of ultrasonography imaging, interpretation of ultrasonography is still not covered in our curriculum. Cost will be an issue in the Indian or the Asian subcontinent, but collaborations, the solution out of this is collaborations. So that might or might not be an issue. It depends on how you approach. But before that, before approaching a radiologist, it is important for us physiotherapists to be aware that we can use ultrasonography imaging. So definitely within the Indian jurisdiction, there is a law, that is the PCPNDTA Act, which is the Preconception, Prenatal Diagnostic Techniques Act of 1965. It was revised in 1994, where this act or this law came into picture to prevent female infanticide. So the repercussions of this law are that definitely the rate of female infanticide definitely has reduced over a period of time, but only a qualified radiologist, someone who has done his MD in radiology after MBBS, can touch the probe. So there are very stringent laws and rules. So no one else apart from a radiologist can use an ultrasonography machine in India. This is the major flaw or con for using ultrasonography imaging in India. So because the laws are so stringent in this particular matter, And obviously we should abide by the jurisdiction and laws which we live in. Coming to the fact or coming to terms that we physical therapists can use ultrasonography imaging is a very far-fetched thought. And the other is, that is why the applicability in the curriculum teaching process is very far away from ultrasonography. I mean, in the physiotherapy context. So the dependency factor here is the highest because I have to depend on a radiologist, moods, emotions, time, and so many things, patient load. And I mean, there are so n number of factors to, get access to ultrasonography, even if I have to collaborate with a radiologist. So I'm completely dependent on him. And obviously a basic training is a prerequisite. I mean, you need to know how the machine works. You need to understand the interpretation. You need to know what you're going to see. So I feel, I can add few hints in the conclusion right now, is that few things like the practical applicability and the training part, I think this can be inculcated in the curriculum at a very early stage. Whether to use it or not can be a different thing. I mean, that is the next step. So right now for us, for we Indian physiotherapists, collaboration is the only solution, only way out. But that does not also mean that we cannot do it. We can definitely use this. And the previous pictures also been in conjunction with the radiologist only. The radiologist has taken, but the other things the physiotherapist has done. So obviously how to use, these are the prerequisites for imaging. I mean, just a brief about this, how to visualize the plane, the view, what type of probe to use, curvilinear or linear, how much should be the frequency of the probe for deeper tissues, for superficial tissues, the mode of ultrasonography, B mode, M mode. There is a new, technique called as elastography in ultrasonography only. Where should be the location of the probe be? To visualize these three muscles, there has to be a standardized anatomical part. So where should the probe be placed? How do you measure the thickness? From what level to what? In what direction should you do it, in the end or in the center or on the other end? How do you calculate activation ratios? This is a one step ahead. I mean, activation ratios mean that out of the three muscles, how do you know if you keep obliques on one side and transverses on the other side? How do you know which is getting activated more? How can you objectively say those are activation ratios? So the thickness of external or the obliques divided by the transverses. And definitely how can we use it for rehabilitation using visual biofeedback? So currently there are two applications of ultrasonography imaging. One is the rehabilitative and the other is diagnostic. Rehabilitative is a bit undermined and less used, and diagnostic is more than diagnosing certain conditions or diseases. But we can definitely use it for rehabilitation. So the Indian literature, if you see, is there is negligible literature. These are the 4 articles which I have done. The effect of yoga on dysfunction. The acromegaly was measured after given mobilization and so forth. So there is almost negligible literature. What I want to drive the point is we are already, the knowledge is there with us, the practical application is there with us, but the awareness that we can use this tool is not there. So that is why the publications which are coming out is also negligible or handful. So is ultrasound imaging just a fashion or a fad? So this is what Hall did in his study. that it has the potential to provide information, measures of muscle and muscle activity, and with no side effects. Here, as I've already said, it is client friendly. There is a visual biofeedback aspect to it. The patient can also see. So the real timeness is the most important. There are a few other patient satisfaction, better outfalls, positive results are automatically reduced. So in the Indian scenario, as I've already spoken on the PCP NDT Act of 1994, this is a major barrier, but does not mean that we cannot use it. So, non-radiologist physicians like not just physical therapists, orthopedicians, anesthesiologists, emergency medicine and intensivists, all these people have similar roles in usage along with physical therapists. So training protocols and introduction of the same in physiotherapy curriculum is a very, very important thing which should be done. And obviously it should be explored more and more. It needs out of the box thinking to just use a simple tool which is so easily available. I have a small message. I will just end this talk. I have a small message by an MD.
Hello friends, I'm Dr. Sanjay Pasuri, radiologist. That ultrasound acts as an eye for a treating doctor, or in our case, physiotherapist. Hence, the anatomy of the patient can be studied like relaxation and activation of the muscle in real time and document an important role in the evaluation. Thank you. Hello friends, I'm Dr. Sanjay.
So there is a long learning curve to go through. And obviously, one last thing that I would like to highlight is this is not foraying into a different field. We should aim to bring the best in both the fields and not, So the bottom line is to create a practical, client-centered and maximizing objectivity in whatever we do as physical therapists. Thank you so much. If there are any questions, I would like to take them.
Yes. This was the presentation from Dr. Sumaya Zareen. Any questions regarding this topic? Yes, you can get in comment from chat box, madam. From Dr. Baranko. Well, the first comment is
from Dr. Yeah, there is a question from Dr. Baranok. Palpation of abdominal transversus. This is a great art. Yes, I agree. We use the muscle kinology test to assess the transversus muscle. Definitely, Dr. Baranok. We definitely use them. But finally, what about the subclinical cases? Is my question is the subclinical cases, that is the ones who have transversus abdominis dysfunction, but maybe thinner individuals or those who have abdominal fat over while palpation. So these people, they get automatically excluded. There is the muscles are lax post pregnancy. What about these cases? So these subclinical cases where the chances of transversus dysfunction is the highest, they are automatically excluded. I definitely agree it is a great art, because if I have a patient coming and in 2 minutes, if I have to evaluate what is the situation, I will use the 2 fingers to palpate the transversus abdominis muscle. But the objectivity in long-term rehab protocols, we need this. We definitely need this. That cannot be done by palpation alone. Sir, you will have to unmute yourself.
Oh, sorry. We use the same question raised from Dr. Baranko. Just you can.
Yes. I have answered. I have answered both.
Yes. Any further questions to Dr. Zaharin? Yes. If you have any questions or comments, you can text in chat box. We will be asking behalf of you. Yes. Thank you so much, madam, for participating in this event.
Thank you so much. Yeah.
Yes, on behalf of organizing committee members of Physiotherapy Congress 2021, I want to thank you for your insight presentation. Looking forward to meet again next time physical event in 2022 in Dubai in the month of May.
Sure. Okay.
Yes, this was a presentation from Dr. Zairin. Next, we asked Dr. Soumya Prasad, occupational therapist, the Stepping Stones group from USA. The title will be Tetrax-based visual biofeedback training for balance dysfunction. Yes, madam, you can go ahead by sharing your slide.
I hope my screen is visible.
Yes, madam.
The topic of my talk today is Tetrax-based visual biofeedback training for balance dysfunction. The most important contributing factor to difficulty with gait and reaching movement is poor balance control or postural control. Reactive balance control is the ability of a person to recover from an unexpected balance disturbance due to slips or trips. This postural control of balance is assessed by means of posturography, which is the quantitative analysis of center of pressure as measured by force placed. Since patients might easily lose interest in performing the stereotypical repetitive weight shifting task, and this lack of interest impairs the effectiveness of the therapeutic exercises, the enriched virtual environments could optimize the motor learning by manipulating practice conditions that engage motivation, cognitive, motor control, and sensory feedback-based learning mechanisms. The visual biofeedback training augments extrinsic information about task success to the performer via a computer screen. Such systems have been applied to the patients with hemiplegia and have shown positive effects related to symmetric weight bearing. The coupling of biofeedback exercises directly to video games has been developed and has received a high degree of interest. The use of center of pressure controlled game-based exercise regimes has been reported to improve subjects' dynamic balance control. Due to their low cost, these video games that are classified under the non-immersive virtual reality systems and are designed on the concepts of neuroplasticity are the most used equipment in rehabilitation programs. The impaired balance has a correlation with functional limitations in children with CP. Hence, therapy programs have increased in postural function as one of their goals, and with the aim of creating increased efficiency in both undisturbed stance and reactive balance control. The use of these center of pressure controlled game-based exercise protocols have been reported to improve a subject's dynamic balance control. The Tetrax has been used to measure this postural stability in various studies. Thus, considering the use of this posturography with neurological patients, the aim of this study was to evaluate the effectiveness of Tetrax posturography system on static, dynamic, and gait balance of a child who was diagnosed with ataxic CP. The study type was a prospective, longitudinal, and descriptive type case study. So going into a brief history about the case, he was a 10-year-old male child diagnosed with clinical ataxic CP. The child had cognitive preservation and independent gait with auxiliary devices, albeit with difficulty in running, jumping, climbing, and descending stairs. The child had no history of previous respiratory, cardiac, or orthopedic diseases and received occupational therapy services at a tertiary hospital in New Delhi, India. The TETRAX system is a center of pressure control video game-based exercise system, which was designed for patients with either an orthopedic or neurological problem. And it is based on the measurement and computerized elaboration of electronic signals emitted by 4 foot plates, 1 for each heel and toe. A TETRAX training program is known to improve the standing stability and is also known as an effective balance status measurement instrument. The measurements are made in 8 different conditions, and each position takes about 40 seconds. The first position is head straight with eyes open on a hard ground. Second, head straight with eyes closed on hard ground. The next is head straight with eyes open, but on soft ground, that is by placing foam under the feet. The fourth is head straight with eyes closed on soft ground, again with foam under the feet. The fifth position is the head turned to the right, eyes closed. Next, head turned to the left with eyes closed. The seventh position is the head backwards at an angle of 30 degrees with eyes closed. And the last position is with the head forwards at an angle of 30 degrees with eyes closed. The vestibular, visual, and somatosensorial inputs are recorded in each of these 8 different positions to evaluate the static postural balance and fall risk of patients. This is what the TETRAX machine looks like. The feet symbols are the force plates, and the screen is where the patient gets the biofeedback from. The intervention protocol: the subject received conventional occupational therapy as baseline for 40 minutes in an outpatient setting, where the subject worked on gait, balance, and motor coordination. He also received TETRAX biofeedback balance training for 20 minutes for 3 days a week for 4 weeks in the same outpatient setting, which was totaling at 12 sessions. During the TETRAX sessions, the following 8 games were used. The first is the sky ball, which involves catching the balls with the rubber glove by moving in the left and right direction, focusing on left and right weight shifting, improving reaction time, tracking a moving object, and attention focus. The next is tag, which involves avoiding the balls hitting the man. This involves anterior posterior weight shifting, improving reaction time, again, tracking an object, and attention focus. The third game is the immobilizer, which focuses on static symmetric weight bearing, weight distribution, and weight transfer by keeping the pressure within the green bars on all 4 sides. The next game is target. This is the multi-directional weight shifting by moving in a direction from the circle to the green diamond to the red triangle and combining the correct balance with the tasks. The next is gotcha, which involves avoiding the balls that are falling from the sky. So you can see in the picture, this involves left and right weight shifting, multi-directional weight shifting, improving reaction time, tracking an object, and attention focus. The 6th game was speedball, which incorporated catching the balls with the basketball hoop, and it focused on anterior posterior weight shifting, improving the reaction time, tracking the moving object, and again, attention focus. The next game was freeze, which focused on full weight bearing of the limbs. The target was to keep the red ball within the green circle. Every time the ball crossed the green circle, there was an auditory alarm that went in, and the target had to bring the ball back inside the circle. The last game was catch, which involved weight distribution, tracking, weight transfers, and attention focus. And it was the aim was to catch the green ball with the red ball, and the green ball kept on moving in different areas of the screen. The level challenge was adjusted by target size, number of targets appearing on the screen at the same time, and speed of target movement. The challenge progression was tailored according to the subject's ability. And at the end of each game, the final score and percentage of correct hits on the left and on the right side were shown on the screen to give a feedback about the subject's performance. The therapist chose 3 to 5 games for each intervention session and demonstrated how to stand on the force plate, how to move the dot on the screen from movements at the ankles without lifting the foot from the force plate by leaning forward, backward, left, or on the right-hand side before each new game. The subject was then asked to try out the game, and before beginning, the therapist verified whether the subject understood the functioning of the feedback system and that the subject had adopted a comfortable and suitable foot position. The other tasks that were done by the subject to target balance were the body stability tasks, such as standing with eyes open, with normal or narrow base of support, standing with eyes closed, kneeling on a hard surface and soft mattress. Combining body stability and manipulation tasks included standing with rapid alternating hand movements, standing on a balance board and reaching in various directions, throwing and catching a ball while standing. The next involved gait balance during gait, which involved walking with narrow and normal base of support, stair climbing, walking backwards or sidewards, walking on a soft mattress, or tandem walking on a balance beam. The last was balance during gait and manipulation tasks, which involved walking while counting alternatively from 1 to 100, walking while carrying books, or walking in a busy hallway. The outcome measures: the subject was evaluated pre and post the 4 weeks of training. The primary outcome measures were the Berg balance scale to analyze the static balance and fall index. The secondary outcome measures were the stability index and weight distribution index. The fall index, the stability index, and the weight distribution index scores were all measured using the tetrax. The higher the stability index and fall index, the poorer the postural control, and the normal weight distribution on each plate was 25%. So if a patient's weight distribution changed, it increased the weight distribution index and showed a poorer postural control. Results: there was an increase in the total score of Berg balance scale from 31 to 45, with most of the progress in items that required standing unsupported with both feet together and eyes closed, reaching forward with outstretched arm in standing, transfers, looking back over the shoulder in standing, turning 360 degrees, alternating feet on a step, standing with one foot in front of the other, and standing on one leg. The overall improvement was of 25%. When assessing his balance via tetrax, the fall index showed the degree of risk of fall on a scale of 0 to 100. The low risk was 0 to 35, moderate risk was 36 to 57, and high risk was 58 to 100. In both the pre and post training, the subject's fall index fell between the high risk zone, with scores being 100 and 89. The pre-intervention weight distribution index score was 7.74 and stability index was 84.44 in eyes open and 5.11 and 151.46 in eyes closed, respectively. The post-intervention weight distribution index scores were 6.14 in eyes open and 3.62 in eyes closed. And post-intervention stability index scores were 74.63 in eyes open and 124.07 in eyes closed. So there was an improvement. This figure shows a plot of the subject center of pressure at baseline and post-intervention. The decrease in the postural sway is clearly visible in the plot, and also the center of pressure is closer to the midline in the post-intervention session than at the baseline. The dot here is the center of pressure. This is the baseline. This is post-intervention, which you can see is closer to the midline, and this is the sway, the postural sway, which is also minimized post-intervention. After Tetrax training, the study showed an increase in the work balance scores, specifically in the items that required standing unsupported, standing on one leg, climbing stairs, and looking back over the shoulders or reaching forward while standing. This was probably a result of the games that the subject played in Tetrax, which targeted characteristics such as motor coordination, weight bearing, and weight displacement, forward and backward sways, the postural adjustments, and balance in a more interactive and playful manner for the subject. Providing CP children with simultaneous visual feedback about postural sway may help in creating a more external focus of attention, that is, the postural sway becomes apparent via the visual cursor movements. This visual feedback of postural sway provides a functional perspective for postural control, which in turn improves the performance of the primary task. In the Tetrax program, the patient stands on 4 fixed flat force plates. The center of pressure can be seen by the patient on the screen, and patients can achieve the required task by moving the center of pressure. The patients move their center of pressure voluntarily by within the limited range of the Tetrax instrument. Also, their feet were required to be always placed on the force plate to accomplish the task. Hence, the beneficial effects of Tetrax may be due to stimulation of the static balance control. Accordingly, the stability index and the weight distribution index scores were improved in both open and closed-eyed positions. Other studies have also proved that using Tetrax has provided functional improvement in neurological patients. According to Hung et al., chronic hemiplegic patients showed improvements in their reaction time, proprioception, and symmetric weight bearing, gait, and forward reach after rehabilitation with Tetrax. And in another study by Libdeb et al. On patients with hemiplegic CP, the visual feedback training using the force plates over 18 sessions, there was an improvement observed for stance and gait. This study had a few limitations. The first off is the small sample size. The next is the duration of the intervention, which was very short, that is for 20 minutes, 3 days a week for 4 weeks, which may have undervalued the effects of the intervention, and lack of follow-up assessment leading to no documentation of carryover effects of the Tetrax biofeedback system. For future studies, the results in this study are not powered to make any definite conclusion about the efficacy of the Tetrax biofeedback training in CP children. Repeating the study in larger and more heterogeneous group of patients with a longer period of intervention will provide more detailed information about the fall risk in different age groups and in specific disorders, and is needed to explore the effects of this intervention. Also, assessing the long-term effects of the Tetrax biofeedback training is also one of the options. In conclusion, using the Tetrax system during the treatment of an ataxic CP child can be of beneficial nature. This is because the stability index and the weight distribution index scores improved in both open-eyed and closed-eyed positions. So a Tetrax program may benefit patients with abnormal proprioceptive function. However, we do need further studies to provide a more robust data about the efficacy of this intervention. These are my references. Thank you.
Yes, madam. This was the presentation from Dr. Soumya Prasad. Any questions regarding this topic? Actually, the drawback is as soon as completing their talk, just they are leaving from Zoom meeting, madam. Yes. because we are having different time zones. They cannot stay whole 8 hours in meeting. No? Just they are going away. Any questions? Yes. Thank you very much, madam, for enjoyed your speech. Pleased with the topic. Looking forward to meet again next time in physical event in Dubai in the month of May. We are expecting. Hope we expect you as one of the plenary speaker for this conference. We'll be expecting more than 7 to 8 speakers for in physical event.
Thank you so much.
Yes, within couple of days you will be getting electronic certificate as well as booklet officially through email ID.
Okay. Thank you.
Yes, I think it's early in the morning, madam, in your region.
It's pretty early in the morning, yes.
Actually, we plan to organize your talk around 5:30 to 6 o'clock according to Indian timings. So we cannot maintain the accurate time. So please apologize.
It's okay. It's no problem. Thank you so much.
Yes, thank you so much. Have a nice day.
You too. Thank you.
Yes. Actually, we are left for one more keynote speaker presentation. Yesterday's talk, that is Dr. Sheila Rohane from Goni LLC USA. The topic will be effect of Goni intervention of knee range of motion, pain, and functional mobility post total knee arthroplasty TKA. So we are going to present her talk in today's presentation.
Total knee arthroplasties are the most frequently performed orthopedic surgery in the United States today, and they are projected to increase to 3.48 million per year by 2030 in the United States. There have been significant advancements and changes with total knee arthroplasty or TKA surgery, whether it comes to the material makeup of the prosthetic implant or the design, whether it's the advanced surgical techniques, including robotic assisted surgery, and artificial intelligence now with smart knees, where they can track patient data after surgery, or advances in anesthesia or better post-operative pain management protocols. Even a transition from inpatient procedure, where the patient stayed in the hospital for 3 to 4 days, to now an outpatient procedure in the United States. Another huge change with TKA surgery in the US is the significant downward trend of the amount of physical therapy coverage available to the patient post-operatively. Patients used to be discharged to inpatient rehabilitation facilities, where they received 3 hours of physical and occupational therapy per day, 6 days per week, for up to the first 3 weeks of surgery. Then there was a transition to skilled nursing facilities, where they received 2 hours per day, 6 days per week. Well, now the trend for the TKA patients in the United States is to be sent home on the same day as the surgery, with a referral for outpatient physical therapy, which is typically a 1-hour session 3 times a week. Or if outpatient is not a possibility for the patient, then they can receive home health services, which is a 1-hour session twice a week. So 18 hours per week to now possibly 2 hours per week is a huge decrease in the amount of skilled physical therapy that post-TKA patients are now receiving. Despite all these positive advancements related to the TKA surgery itself, and knowing the prevalence of TKA is rapidly increasing, rehabilitation techniques do not seem to be evolving at the same rate in order to fill this large gap in skilled physical therapy services. Now, physical therapists have increased their knowledge on adjunct therapies like dry needling or taping or scar tissue management. They've advanced their manual skills like in joint mobilizations or different stretching techniques. They may have increased knowledge on modality use, like pulsed shortwave therapy or various cryotherapy techniques. And physical therapy gyms tend to have lots of equipment that vary in size and cost at their disposal to use with their patients, while in treatment sessions, like recumbent bikes, fancy peddlers, or new steppers. However, the greatest lag in the progression of rehabilitation techniques can be seen specifically in the home exercise program prescription to the patient, meaning what we tell the patient to do at home has not changed significantly in the past 20 years. We continue to prescribe home exercise programs that include mainly passive or active assisted exercises that we cannot control for compensatory movements while the patient performs these at home. So despite our hands-on skills improving and use of adjunct therapies and modalities increasing and ample availability of equipment during physical therapy sessions, what have we as rehabilitation specialists done to help the patient when not in formal therapy sessions? We can all agree that despite the surgical advancements and improvements in post-operative medical care, the importance of physical therapy after TKA continues to be crucial for the patient's physical recovery. Yet, there is a significant gap between the quality of treatments received with the physical therapist compared to what we prescribe for the patient to do at home. Knowing the healthcare system is transitioning to less and less formal therapy services simply because it cannot meet the financial demands of this growing population, it is that much more important what the patient is doing at home on their own to help their knee recovery. So let's take a look at some research findings related to TKAs. Wild et al. Found that a large percentage of patients continue to report having persistent pain after surgery, with some rating it severe to extreme pain even 1 year after surgery. With regards to range of motion, Yoshida et al. Found that post-TKA patients are not comparable to their adult counterparts who do not have osteoarthritis or a history of TKA. And patients are commonly being discharged from therapy and still presenting with functional deficits even 1 year post-operatively, according to Bade et al. They reported a 40% deficit in quadricep strength, 51% slower stair climbing speed, 18% slower gait speed, and they also saw deficits in knee range of motion and timed up and go times when compared to healthy older adults. Now let's keep in mind that those were research statistics from over a decade ago, when patients were receiving hours of daily skilled therapy services, some as many as 18 hours of therapy per week. So what does that mean for the future TKA patient who may only receive 2 to 3 hours of therapy per week? This patient population deserves something better. TKA surgery is not going away. In fact, it is increasing in incidence all over the world. And it is imperative that we find solutions, alternatives, emerging technologies, and new equipment that are available to the patient themselves, something they can do on their own, outside of their therapy session. They need a superior home exercise program. And this is the reason GoKnee was invented. Before we can discuss what the research said about GoKnee, we need to know what it is. GoKnee is a home exercise program that was created by physical therapists to expedite the rehabilitation process after TKA surgery. GoKnee has 2 components. 1, a patented knee device, and 2, customized exercise protocol that comes in an easy-to-follow video format that the individual does on their own as part of their home exercise program. The GoKnee device was designed to improve range of motion through the orientation of the horizontal pads. The pads are adjustable and move up and down and can provide enough torque at the knee to mimic the hands of a therapist and that of a joint mobilization. The device is made of materials that are familiar to the patient, therefore not intimidating, and it is lightweight and portable. Now, the GONI protocol was created after an extensive review of literature and research on exercise principles, pain neuroscience, neurological recovery, and chronic pain. The protocol uses the pad orientation of the device to improve range of motion through sustained stretching, joint mobilizations, and the use of muscle energy techniques like contract, relax, and isometrics. The protocol has a strong focus on improving the patient's end available range of motion through the use of progressive angular isometric loading. GONI program addresses flexion, extension, and strengthening of the knee all in one device. Another key component of GONI is that the patient is in full control of the device at all times, thus allowing the patient's nervous system to feel safe. This means less resistance from the patient and less muscle guarding compared to when therapists place their hands on the patient's swollen and painful knee and we tell them to relax. We all know they don't relax when they know something is going to hurt. Instead, they brace themselves. With the patient being in full control of the device and the brain feeling safe, more knee motion is actually granted. The GONI protocol incorporates neurological principles of recovery into its exercise program. Now let me explain further why this was so important to the creators of GONI. They believe that the neurological component with TKA recovery is grossly underestimated and undertreated. The typical TKA patient has experienced chronic knee pain for years leading up to the surgery. There is research emerging regarding pain neuroscience education and its relevance with chronic pain, and it applies to TKA patients as well. Just because the surgeon removed the bone with the arthritic changes does not alter the fact that the brain has been protecting this knee joint for years, and this is not simply erased from the brain's memory after a surgery is performed. It is vital in the rehabilitation of TKA to incorporate neurological principles of recovery. A PT once said, TKA is an orthopedic surgery, but a neurological recovery. The creators of GONI, being physical therapists, had seen firsthand the effect GONI was having on their own patients. They had over 50 years of collective clinical experience, and they used that knowledge and experience to pull from and realized their TKA patients were regaining active range of motion quicker. They were seeing end range quadricep control return faster, which in turn resulted in a faster progression from walker to cane to no ambulatory device without compromising gait quality, symmetry, or safety. Now, they also understood the limitations in anecdotal evidence and therefore sought out academic institutions that could conduct independent research to legitimize the efficacy of GONI. This is where Belmont University in Nashville, Tennessee came into the picture. Now that you have a better understanding of what GONI is, let's take a look at the Belmont study. They looked at the effect of GONI intervention on knee range of motion, pain, and functional mobility post-total knee arthroplasty. Belmont's Doctorate of Physical Therapy students led the research study. They did a poster presentation of the results in November 2019, however, was not published until this past month. The delay was related to COVID, which I am sure everybody on this call has had some dealings with, and the healthcare providers that wrote the article had to put it on hold to focus on patient care and other priorities due to the pandemic. The purpose of this study is to investigate whether the use of GONI significantly improves objective and functional measurements following a total knee arthroplasty. The number of participants in this study was based off the total number available at the data collection institutions. So a total of 29 participants were included, ranging from 50 to 90 years of age. Inclusion criteria were any male or female who had recently undergone a TKA and were receiving physical therapy services through a skilled nursing facility or home health. There were no exclusion criteria within this population. All data was collected by licensed physical therapists. The participants used GoKnee as part of their post-operative rehabilitation in conjunction with traditional TKA interventions. And as we mentioned earlier, GoKnee protocol included knee flexion, knee extension, and strengthening using the device. The study used a repeated measures design looking specifically at the relationship between the independent variable of the length of time post-surgery and the dependent variables of pain, knee flexion, knee extension, tug scores, gait speed, and 30-second sit-to-stand score, and were recorded at various times throughout the patient's treatment sessions. The data points were categorized into 4 timeframes for data analysis: postoperative days 2 to 6, postoperative days 7 to 11, 12 to 16, and then 17 and above. All data collected was analyzed in these groups using SPSS version 25. Descriptive statistics were reported for all time categories for each dependent variable. A paired t-test was used to compare means between time frames and report statistically significant improvements in time. Due to the number of possible combinations, a Bonferroni correction was used to decrease the risk of a type 1 error in the reported results. A corrected p-value of 0.008 was used for all comparisons. Results showed significant differences were found in all variables from postoperative days 2 to 6 to postoperative days 7 to 11. That means patients demonstrated significant improvements in the first 2 weeks postoperatively when supplementing traditional therapy interventions with GoKnee. Now, in 2008, Lenson et al. Looked at outcome measures in patients using a continuous passive motion machine, CPM, following TKA. The study found that CPM range of motion was better than the control group for both knee flexion and extension. Now, these measurements were of passive range of motion. GoKnee not only showed better range of motion in both flexion and extension in a shorter time period, but their gains were active range of motion gains, not passive. And this is important because there is ample evidence available that shows that passive range of motion gains do not necessarily translate into functional gains. A 2010 study with Bate et al. Followed up with 24 patients at 1 month post-operatively following a TKA, and they looked at active range of motion measurements in both flexion and extension. As you can see, GoKnee data showed improvements in both measures, flexion by 16 degrees and extension by 5 degrees. Important to point out that GoKnee obtained these measurements by postoperative day 17 compared to Bate et al.'s group of postoperative day 30. A 2019 study by Iwata et al. Collected data on 49 subjects following a TKA to analyze the effect of quadriceps strength on gait function. The researchers measured tug scores at 2 and 3 weeks postoperatively. The table shows tug scores with GoKnee were slightly slower. The Iwata study did not mention what ambulatory aid was being used by the patients, nor whether gait asymmetries or compensatory movements were discouraged. 90% of GoKnee patients were using a straight cane at 2 weeks, with an emphasis on gait quality and symmetry, which could explain the slightly higher tug time. This table shows those using GoKnee had slightly slower gait speeds compared to the subjects of Iwata's study. Iwata's study did not specify what assistive device was being used, nor was there any description of gait pattern during the testing. Given that the subjects using GoKnee were encouraged to focus on gait symmetry and quality, This could again account for slightly slower gait speeds. The authors of the Belmont study stated the following limitations of their current research study: a lack of a control group, all data was not collected on the same day post-operatively for each patient. This is to be expected with patients in a skilled nursing facility or receiving home health services, as the amount of time and days each patient will be seen can vary. Time frames assessed do not allow for any conclusions to be made about the long-term benefits of GoKnee. The authors of this study have no conflicts of interest. The current study received no grants from funding agencies in the public, commercial, or not-for-profit sectors. There was no financial support for this study that could have influenced its outcomes. So what do we know about total knee arthroplasty rehabilitation? That there is currently no standardized treatment approach post-TKA surgery. There is a definite need for more research on proven rehabilitation interventions that work, given the growth that is expected with TKA surgeries all over the world. Now, this was a pilot study to examine the effects of GoKnee. Given that the data was very positive and revealed that GoKnee did improve outcomes in the early phases of rehabilitation following a TKA, the next step would be a randomized controlled trial. That is, comparing the use of GoKnee with a control group receiving traditional interventions and to assess possible long-term benefits of use. Unfortunately, this has been on hold due to the pandemic. The reality is, until the pandemic is under control, most in-person research is on hold in most locations in the United States. What we do know is that post-TKA patients continue to present with long-term deficits, whether it's pain or a slower stair climbing speed. We also know that insurances cannot keep up with the demands for TKA patients, and that trends in decreased healthcare expenditures will continue. That means that the patient will have less access to skilled physical therapy services post-TKA. As healthcare professionals, we know the importance of an intensive rehabilitation program after this surgery to ensure optimal outcomes. So it is imperative that we find solutions for TKA patients to fill this gap of less therapy services being provided to them. Now, we saw today that GoKnee shows promising results in the ability to help post-TKA patients in their recovery. GoKnee has shown components that prove it is a superior home exercise program than what is currently being prescribed to patients. This is due to their evidence-based exercise protocol that focuses on active movement, the ability to perform more aggressive sustained stretching, and muscle energy techniques in the patient's end available range of motion. Also, the ability to perform a joint mobilization at the knee without a physical therapist present, all while the patient is in full control and is used in the patient's own home as part of their daily home exercise program. GoKnee could potentially improve patient outcomes and patient satisfaction. Using the GoKnee program could result in cost savings for the patient. For instance, less co-pays for therapy visits, less time off work because of a quicker recovery, possible delaying the need of additional surgeries or procedures. And if the claims on how quickly GoKnee can improve the patient's recovery are accurate, then the potential to significantly reduce total healthcare expenditure following a TKA is huge. This has tremendous implications for insurance agencies, as well as countries where the government provides the care and services for this population. The US alone spends hundreds of billions of dollars every year on total knee arthroplasty. Now, to be respectful of time today, I will not begin to discuss the potential impact GoKnee could have on prehab, meaning pain management before surgery. improving soft tissue integrity in preparation for the upcoming surgery, and subsequently the impact this could have on patients with chronic knee osteoarthritis. Now that was a lot of information in a short period of time. Thank you so much for your time. It was my honor to be able to tell you all about Go-Knee today.
Yes.
As a co-creator and CEO of Go-Knee, I would encourage all those attending and listening to take time to reach out to ask me any questions about Go-Knee, whether it's the recent research, future research, or any advancements we have made to our product since we broke into the market following the research in 2019. Please feel free to reach out on these social media platforms, either through email, the website, or LinkedIn, and I would be more than happy to answer questions.
Yes, this was the presentation from Dr. Sheila Roney, the keynote presenter of the day 1. Please let me know any questions regarding this topic. Any questions regarding this topic, so that we'll be sharing officially the question you asked to the concerned speaker. Any questions? This was the keynote presentation. Yes, thank you so much, madam. Thanks you so much for speaking up in this meeting and providing a unique perspective. Thanks for sharing your tips with us. Looking forward to meet you again next time in physical event if everything goes well in 2022. We also expect your presence as one of the keynote speaker for upcoming Dubai 2022. Yes. If you go to the next speaker, that is Miss Kavita Bakshi, Department of Allied and Applied Sciences from University of Patanjali, Haridwar, Uttarakhand, India. The topic will be effectiveness of yoga in knee osteoarthritis, a narrative review. Yes, madam, you can start your presenting by sharing your slide. So this was the topic.
Namaste everyone, greetings from India. So I'm Kavita Bakshi. I'm a PhD scholar in Department of Allied and Applied Sciences at the University of Patanjali. Am I audible clearly?
Yes, it's
fine. Okay. So I'm working as a PhD scholar in Department of Allied and Applied Sciences, University of Patanjali, Haridwar, Uttarakhand, India. So my topic is effectiveness of yoga in knee osteoarthritis condition. So let's start.
Yes, madam, go ahead.
So let's start with the introduction on osteoarthritis. What is osteoarthritis? It is the most common type of degenerative arthritis condition. This is the most common and leading cause of disability among elderly. You can see into this picture one is knee osteoarthritis condition depicting over here. The joint surfaces are getting exposed with worn out cartilage and there are osteophyte formation into it, which further leads to synovial inflammation and pain and stiffness occur, which leads to disability amongst elderly people. It is a very prevalent condition. It affects 7% population globally, according to the study published in Lancet previous year. So about 500 million people are affected with this disease globally. So now introduction about yoga. It is a mind-body practice. This was originated
Hello. 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 Yes, Miss Kavita, just we ask you to join the meeting again. I think you exited from this Zoom meeting. I think you are having poor internet network. If you go to the scientific program, we do have three more speakers. That is Sahed Wahed, Dr. Saman Saleh, Dr. Abdul Azab Bhatt, as well as one of the speaker from India, that is Dr. Isha Akulwar. So we do have three speakers apart from Dr. Miss Kavita. Yes. Yes, madam, you can go ahead.
Hello.
Yes, you can go ahead.
So I was giving introduction about yoga. It is a mind-body practice originated. It is a mind-body practice that originated in Indian subcontinent 5,000 years ago. So through text, it says it is the union of your mind, body, and soul. But modern context, the definition of yoga has been changed. It is a systematic practice and implementation of mind and body in the living process of human beings to keep harmony with self, with society, and with nature. In simple terms, it is a harmony of you, the society, and your environment. So, but these days, therapeutic effects of yoga are being studied a lot. It has been proven in various psychosomatic disorders, yoga has shown to be very effective. So, coming to the rationale of study, this is there is no permanent treatment option for osteoarthritis other than going for arthroplasties. First line of treatment according to American College of Rheumatology guidelines is educating the patient about their disease, giving them various means like hot bath or giving those hot packs to relieve their symptoms, and giving them NSAIDs, non-steroidal anti-inflammatory drugs. But issue with these drugs is they cause gastritis, acute kidney injury, and even cardiovascular complications like myocardial infarction. So through a study published in Nature, this has been proven that NSAIDs can cause various various damages to body. So even if you don't go for NSAID, there are other options like opioids available, but there is disadvantage of opioids as well. They can make you dependent on them for lifetime. So hence there is unmet need to relieve symptoms to improve knee function and quality of life. Here, yoga comes as a ray of hope for the safer management of knee osteoarthritis because other treatments are not much safe. So my objective of the study was to find out the efficacy of yoga practices in knee osteoarthritis condition through various RCTs done between 2016 to 2021, and to find out if there were any lacunae in studies for further improvement in research in this field. So I took up literature search, and 35 studies I found. Those were between 2016 to 21, which which were about yoga intervention. And sources I have taken were PubMed, 27 studies I found there, Google Scholar 8, and Science Direct 6. Keywords that I chose were yoga, knee osteoarthritis, yoga module, knee degenerative joint disease, and RCT. So I only took up the RCTs. I excluded the reviews, meta-analysis, and other duplicate studies, and found out the 8 studies were much relevant. So what I found was, through various studies, one study was a RCT done on 98 Chinese people. Those were having knee osteoarthritis. They were given an intervention of yin yoga for a year, and it was found that through BOMEX score, through SF36, that is for quality of life, and anxiety level were checked. Those two both parameters, anxiety level and quality of life, were much improved in the yoga group as compared to the just conventional treatment group. So yoga has shown its efficacy in terms of reducing anxiety level and giving a better lifestyle. So in another study, this was a pilot study done to compare chair yoga intervention with chair-based exercises in biopsychosocial impact on older adults. Both programs in this study showed that physical functions were improving, mobility was better in these adults. And I'd like to quote that the average age in this study was 79 years. So that much old people. They were intervened for 8 weeks, and yoga showed to be a very effective as well as a safer treatment approach. Now, the same authors later did a RCT. This was a 2-arm parallel group RCT done in knee osteoarthritis condition, where 98 individuals were selected. They were given chair yoga intervention. And then it was found that there was reduction in pain inference, and fatigue level as well, and gait speed. So as in previous speaker was saying that those who are having arthroplasties or even knee osteoarthritis, they are not able to move properly. Their speed of gait that reduces. This study showed that with chair yoga intervention, their fatigue level was reduced and their speed of walking was improved. In another study, this was again RCT, 12 weeks of yoga intervention showed that in a 3-group parallel study, in which the first group was given yoga along with medial thrust gait exercises. Second group was given knee strengthening exercises to strengthen the quadriceps muscle and hamstring strengthening along with it. And the third group was just given treadmill walking for 12 sessions. Total 59 patients were enrolled into it. It was found that yoga with medial thrust group showed reduced medial joint load. Most of us are physiotherapists over here, and we know that medial compartment gets affected in osteoarthritis a lot. So this intervention, yoga with medial thrust, gives a very good result and reduces the joint load in medial compartment of the knee. So this was study published in NJ. In the next study, this was a 12-week intervention. Participants had a greater knee flexor movement. The gait was analyzed in this RCT. 40 women were enrolled, and their gait was analyzed pre-treatment and post-treatment, instant effects of doing yoga were analyzed through this. Through this 12-week intervention, it was showed that knee flexor movement at push-off phase, when the foot is getting lifted up, and the greater hip flexion movement was there in the stance phase when the foot is up in the air during the gait. So in those two movements, this showed that gait pattern was getting much better when yoga intervention was given for 12 weeks. Biomechanically based yoga is being talked about these days. So in another study, this was a 12-week intervention along with a parallel group, parallel control group that showed better efficacy and reduced joint load. Clinical outcomes improved in biomechanically based yoga approach more. Sometimes yoga is shown as a culprit of being unsafe, but when it is tailor made for the condition or for the patient, then it becomes much more effective. So through this research, this 12-week intervention, it showed that biomechanically based yoga approach is much better than the conventional treatment approach. In another RCT, in older adults comparing yoga, aerobic strength training, and educating a control group study, it was shown that OA symptoms, the pain perception, be it gait or anxiety level and fear of falling, were comparatively lower in the yoga group. The mind-body intervention may have added benefits to older adults with OA. So now coming to why yoga works. The possible mechanism I am quoting, a full-fledged study needs to be done how yoga works, which leads to improvement or betterment into the condition. Anatomically speaking, yoga improves the deformity associated with knee osteoarthritis. Varus and valgus deformity in the knee develops with OA. And when you are practicing yoga, the joint range improves, muscle becomes more pliable, alignment of the joint improves, flexibility enhances in the muscle and joint, and muscles get strengthened. So the alignment of the joint gets better with yoga. Physiologically speaking, there is improved circulation into the joint area, which reduces toxins and removes the various inflammatory biomarkers and other metabolites that occur and improve the degeneration into the joint. So when these get washed off with exercise or with yoga, then physiologically this helps joint to in the betterment and reduction of pain. Yoga is a combination of asana, pranayam, mudra, dhyan, band. So the pranayam, which are the breathing practices, they augment cerebral blood flow and oxygenation occurs. Thereby, it improves the neuronal activities of the brain centers, including those present in limbic area, hypothalamus, and medulla. So this improves the sympathovagal outflow. The heart rate gets affected by breathing practices that are part of doing yoga. So this leads to a balance between sympathetic and parasympathetic system. Heart rates get regulated, and other system, when they work properly, the musculoskeletal system also functions better. This reduces other inflammatory conditions and improves the joint function. Speaking about glands, pineal, pituitary, and adrenal glands play an important role in the regulation of metabolism, and these are affected by doing Bhastrika Pranayam, according to a study published by International Journal in Disability. So various pranayam and asanas have been proven to be effective in osteoarthritis condition. When we talk about molecular level, yoga has already been proved to be effective against degeneration through various studies. It reduces pro-inflammatory biomarkers like VEGF, vascular endothelial growth factor, brain-derived neurotropic factor. These play a prominent role in inflammation. Also, it has been shown to increase the amount of anti-inflammatory biomarkers like beta endorphins. Beta endorphins, when they are increased, they reduce the pain sensation, and tumor necrosis factor alpha which is prominent feature present in inflammatory condition. So by regulating these biomarkers at molecular level, yoga is showing its effectiveness. Also, yoga has a psychosocial impact. Mostly yoga happens in groups. So when patient goes out, does activity in a group, oxytocin releases. Oxytocin is a love hormone, or that develops sympathy with other people, or you can say bonding between people. So socially it helps in that way. Also, yoga improves your mood and reduces pain perception. Dopamine makes you feel good, and endorphin reduces your pain perception. So various studies have shown that there is psychosocial impact of doing yoga. So through various studies that I have included in this paper, the gaps that I found were most studies were having small sample sizes, and the intervention was given just once or twice in a week. If the frequency of the intervention is improved, I'm sure the results may turn out to be much more better. Yoga is a vast field, and the practices included mostly are not clearly described, which reduces replication of the result. And for a research to be a good one, replication has to be there. So if one school is practicing one asana in a way, the other school practices the same asana in different way. So in every research, it has to be described very well what practice they are including, their name, and how they are performing it. Also, the duration of the studies were lesser, a few weeks only. There was just 1 or 2 studies that were long duration, 1 year or more. So what we can do is we can improve yoga research studies by improving the methodology of the studies, reducing bias, studying long-term adherence to yoga practices, which becomes a real headache because people usually don't adhere to interventions. So we have to ensure ways to improve the adherence to yoga practices. And to assess the long-term benefits of yoga, long-term studies need to be incorporated. And analyzing particular components of yoga therapy in order to obtain a clearer idea about particular types of yoga and the benefits thereof. There are various branches, various parts of yoga, and when each and every part is studied particularly and objectively, then research gets better. If more and more studies will be done through yoga, better evidence will be generated, and we can establish a cost-effective and safer treatment for growing geriatric population. As I said earlier, that 500 million people globally are getting affected with it. And with the growing population, this number is going to increase further. Also, lower burden on healthcare system. The previous speaker was talking about arthroplasty. So if there are if large number of osteoarthritis patients will be there, arthroplasties will be more, and there will be huge burden on healthcare system. And to decrease that, better approaches like this non-pharmacological approach of yoga needs to develop. For that, evidence needs to be generated. Or also, quality of life years will be added to the patients suffering from long-standing disabilities. And osteoarthritis is the main culprit behind long-standing disability. Also, there will be lesser patients going to the provider clinic when they'll be feeling better at their homes by doing just yoga practices. So adverse drug events that occur through various NSAIDs or other drugs, that will reduce. A good evidence will be generated in favor of Indian medical system's effectiveness. So Indian medical system will get better evidence if more studies, better studies are being done in this field. Thank you. If you have any questions, then you may ask.
Yes. Any questions to is Kavita? Just if you have any questions regarding this topic, you can text in chat box. We'll be asking. We'll be asking information of the conference. Yes. Thank you so much, madam. Thank you for sharing your tips.
Thank you, sir.
Looking forward to meet again next time in physical event if everything goes well in 2022. We are going to choose Dubai as a venue for upcoming physical event. If you're willing to participate, to join as a speaker, so now we'll be requested to get ready for by Inovine itself. Yes.
Sure, sir.
Yes.
Thank you so much.
Yes, you'll be getting electronic certificate as well as handbook. Will send through email ID in 3 to 4 working days after the completion of the conference.
Right.
Yes.
Thank you, everyone. Greetings from India.
Yes. Thank you very much. Have a nice day. Yes. Next we ask Dr. Aisha Akulwar Tajane, Associate Professor in Neurophysiotherapist at KG's Somaya College of Physiotherapy from India. Yes, madam, go ahead by sharing your slide.
Hello, sir. Hello, everyone. Just give me 2 minutes. I'll start sharing my screen.
Yes.
Yes. Are you able to see my screen, sir?
Yes, madam.
Hello, everyone. I'm Dr. Isha Akulwar Tajane. I'm a neurophysiotherapist from India. And it is indeed my privilege to be a part of this esteemed conference. And I extend my heartfelt gratitude to the organizing committee for inviting me on this global platform. The title of my talk today is Shoulder Subluxation in Stroke, its clinical implications. This is a review which the shoulder or glenohumeral joint subluxation which happens in stroke. All of us know that stroke is a leading cause of serious long-term disability in adults. More than 60% of stroke survivors suffer persistent neurological deficit. Upper dysfunction is one of the most challenging sequelae of stroke. Attributed to motor control deficits. Background disturbance.
Yes, madam. We are getting a low voice from your side. Just
now, can you hear me better?
Yes. You can go ahead.
The prevalence of upper limb impairment is approximately 50 to 80% in the acute stage and 40 to 50% in the chronic stage. The ability to integrate the affected or the paralyzed upper extremity into purposeful functional tasks is limited by several factors, including pain in the shoulder, contractures, deformities, loss of motor control, weakness, orthopedic limitations, loss of postural control, learned non-use, loss of biomechanical alignment, inefficient and ineffective movement patterns, etc. The frequently observed upper limb impairments after stroke are paresis, abnormal muscle tone, decreased somatosensation and coordination. And these impairments in the upper extremity after stroke in turn lead to shoulder subluxation, adhesive capsulitis, impingement syndrome, and rotator cuff injuries. Well, all these were the common upper limb impairments which happen or occur after stroke, and especially in those with substantial upper limb weakness, vertical glenohumeral subluxation can develop, causing a downward migration of the humerus and eventually resulting in hemiplegic shoulder pain. Shoulder subluxation is probably the most cited complication after stroke. It is reported to be present in up to 80% of the patients. In a systematic review, the range of shoulder subluxation was from 17% to 81%, depending on the duration of the stroke. Well, it is considered as a non-traumatic partial or total change of relationship between the scapula and the humerus in all directions and planes as compared with the non-affected shoulder. And in the definition, it is important to mention that this impairment occurs after stroke or is attributed to the stroke. It is considered as one of the most common secondary musculoskeletal problem after stroke and most cited problem causing shoulder complications. Now, well, which are the shoulder muscles? Which are the complications? Sorry, just a second. Sorry, just a second. There is some technical problem. Okay. So prevention and management of shoulder dysfunction is an important goal in rehabilitation of stroke patients at every stage, right from the inpatient to the complete recovery and discharge of the patient from rehabilitation. So the aim of the current review was to gain a better understanding of the factors associated with shoulder subluxation, which will guide the assessment and monitoring of shoulder subluxation. And ultimately, it will help to develop the management strategies to prevent or further to reduce the shoulder subluxation. Now, coming to the theoretical framework related to this topic or talk, review of literature. Literature search was conducted using the keywords stroke, shoulder subluxation, and its management. Before going ahead with stroke, the biomechanics of shoulder stability was reviewed, and it revealed that the glenohumeral joint relies heavily or completely on the integrity of the muscular and capsular ligamentous structures rather than the bony conformation for its stability. And in shoulder, the specific upper limb impairments related to the motor control deficits include paralyzed shoulder cuff muscles or the rotator cuff muscles, which are no longer able to anchor the shoulder joint. And especially when the hands are kept hanging, the gravity will pull the shoulder or the humerus down further. For this topic, the type of studies identified or obtained were systematic reviews, some prospective cohort studies or longitudinal studies, and also some retrospective analysis type of studies were identified. However, overall, it is seen that in the literature search, that evidence is still needed to support clinical decision making related to shoulder subluxation in stroke. Well, the directions in which shoulder subluxation can take place is inferior, anterior, or superior. Out of these, the inferior is the most common direction, followed by anterior. Sometimes even a combination of inferior and anterior subluxation is seen. There are some proposed etiological mechanisms which are mostly related to the biomechanical alterations which take place after stroke in the paralyzed upper extremity. Shoulder subluxation is very common during flaccid more than the spastic stage. It happens due to the paralyzed shoulder muscles, as we said, which are no longer able to hold the humeral head up against the gravity. Just a second. Yes, and especially as we said, when the shoulder, the entire upper extremity is kept hanging, the gravity would pull the shoulder joint down and resulting into a subluxated shoulder. Improper positioning, especially during the acute state, can also lead to shoulder subluxation. So improper positioning is identified as one of the most common factors related to etiology. Lack of support in the upright position. So as gravity acts on the shoulder, pulling the hemiplegic arm down. Also, certain motion activities without appropriate joint mechanics or support aggravate the condition. Now here the motion activities could be therapeutic as well, such as certain therapeutic exercises, or even if the patient tries to do some active exercises without proper support at the shoulder, such as pulley exercises. So these could be detrimental to the shoulder integrity and should be properly monitored by the therapist. Scapula orientation. So when we talk about the shoulder, it is also important to look for the scapula, which tries to stabilize the glenohumeral joint. So its orientation, when it gets altered, especially when the scapula rotates downward, there are high chances that the humeral head will also be oriented accordingly and can result into shoulder subluxation. Literature is controversial. However, even some sensory impairment at the shoulder is identified as a precipitating factor for shoulder subluxation. Now, further supporting that, the muscular function, damaged muscular function at the shoulder is an important etiological factor. Certain studies have been carried out which prove that higher incidence of shoulder subluxation is seen in patients with complete or severe arm hemiplegia as compared to milder paralytic involvement. Well, Brunstolm's arm recovery stage, what we consider for motor recovery of upper limb, is a significant predictor of shoulder subluxation. So in those studies, it was seen that lesser or lower the stage of recovery of arm function, more or high chances of shoulder subluxation was found. Motoricity index, that is again related to, or it is again another outcome measure to determine the arm motor status. It also shows that lesser the score on this index, more severe, more frequent or severe is the shoulder subluxation in stroke. Also, another evidence is that spontaneous reductions in the subluxation are seen when there is significant motor recovery in the upper limb. So all these studies and evidences support that one of the most important risk factors or etiological factor for shoulder subluxation in stroke is the paralyzed upper extremity function. Now, as we talked about the glenohumeral joint, that it heavily relies on the musculoskeletal, on the muscular system, structural integrity of the glenohumeral joint is lost when there is shoulder subluxation, and this image shows that how the humeral head or the entire humerus is subluxated distally. There are certain grades which are assigned to this amount or the severity of subluxation. You can see in the image 0, which is normal, followed by 1, 2, or 3 subluxation grades, or further ultimate disintegrity can be called as dislocation and is assigned a score of 4. Well, just a second. Overall, the impairments associated with this shoulder problem is the malalignment at the shoulder. Sometimes a patient may experience pain in the shoulder, or at other times the shoulder subluxation may remain painless and ultimately it does remain unnoticed by the therapist or by the patient himself or herself. It may result into stiffness at the shoulder. Because of the pain or overall malalignment, the patient may not be willing to move the shoulder either actively or passively. Muscle shortening, because of again this malalignment, certain muscles are likely to undergo shortening, and those are the biceps, the adductor or the pectoral muscles, the latissimus dorsi, and also the subscapularis muscle. There will be loss of upper body alignment. These are the postural deviations due to shoulder subluxation related to the upper body alignment. Especially there is loss of vertical asymmetry, and there can be a trunk lean on the hemiplegic side. So postural deviations should also be a part of the comprehensive assessment of shoulder subluxation. When the patient regains the ability to move the paralyzed side, there will be improper scapulohumeral rhythm because of this malalignment. So the overall consequences of shoulder subluxation include shoulder pain or arm pain. Further, it can lead to shoulder hand pain, or which is also considered as reflex sympathetic dystrophy. There can be high chances of rotator cuff injury If this malalignment is not corrected and still the patient's shoulder or the entire upper limb is moved in an inappropriate manner, injury can also occur to the neurovascular tissues around the shoulder joints. There can be dysfunction of the brachial plexus and other peripheral nerves around the shoulder. Limitation of movement, as we discussed about the stiffness or improper movement, improper movements occurring at the shoulder. Ultimately, this leads to delayed neurological recovery. And just a second, sorry. Yes, the pathomechanics at this skeletal level does not provide the structural base for the neural motor recovery. The increased distance between the acromion and the humeral head delay the recovery of upper extremity neurologically, and also it hampers the functional recovery of upper limb. As we know, good shoulder function is a prerequisite for successful body transfers, maintaining balance, performing activities of daily living, and for effective hand function. Thus, this delayed neurological recovery, poor arm functional recovery ultimately negatively affects the rehabilitation outcomes post-stroke. Well, coming to the, this highlights that it is very important to detect the shoulder subluxation very early, as we have seen that it can happen even in the flaccid stage, and also that it may not be associated with any overt symptoms such as pain. So very likely this important, very serious complication at the shoulder may remain unnoticed. So it is very important to suspect this complication, and also to be vigilant in monitoring it right from the early stages of stroke. Well, exposing the part is important to identify this complication or malalignment. So always expose the shoulder and arm region. Also palpate the shoulder region, especially the acromion process for scapular malalignment, as well as definitely the humeral head, and identify the direction in which the humerus is seems to be subluxated. As we said, it could be most commonly in the inferior direction, or could be also in the anterior direction. So this is how the patient may present with shoulder subluxation. You can see that there is an identifiable gap between the acromion and the humeral head. When we palpate the space, we can find a sulcus sign. Also on observation, this sign which shows a gap is called as a sulcus sign, and this is also associated with gross muscle wasting. As you can see, loss of muscle bulk around the shoulder region, especially the rotator cuff muscles, including the deltoid. And objectively, clinically, we can actually measure the distance to know the severity, or to quantify the displacement of the humerus in the inferior direction. This can be done by placing the fingers between the acromion and the humeral head. The finger breadth, how many fingers can such be placed, will give us a rough idea of how much is the subluxation, or it can also be measured with an inch tape or a measuring tape. Well, the X-ray of the shoulder region will be the best method for quantifying the glenohumeral subluxation. And as we need to know as we are aware that it will be seen in the inferior direction under the influence of gravity, an ideal X-ray should be taken with the dependent position of the arm or upright position of the patient as a whole. Well, that was about the assessment part of shoulder subluxation. Just a second. This post-stroke shoulder subluxation is thought to be irreversible without intervention. So the management of subluxated shoulder, as we said, is one of the very important goals of rehabilitation of patient with stroke. However, it has always been a challenge to rehabilitate an already subluxated shoulder. Very limited studies or very limited evidence is there that once the shoulder subluxates, it can be corrected or can be brought back to its correct alignment. So it is very important that we prevent the shoulder from subluxation. And as we said, or we discussed, that it is very important to detect the problem early. However, the prevention strategies start right from day one of the stroke, which include proper positioning of the patient's whole body, especially the upper limb and especially the shoulder region. Second important thing, and very, very important thing, is the proper handling and transfer techniques by the caregiver, which can be done with proper education of those people. Maintaining proper alignment and mobility of scapula is another consideration. As we said, the scapula, when rotated downwards and becomes immobile on the thoracic cage, can further aggravate the gravity acting on the humeral head. Also, there are studies which use external support devices for the upper limb, such as a sling. I'll be discussing one point in detail further. Certain muscle facilitation techniques, especially targeting the shoulder region, such as deltoid, rotator cuff muscles, scapular muscles. Also, certain postural deviations should be corrected by giving appropriate muscle facilitation techniques. So this is an active part of rehabilitation of shoulder subluxation, and also electrical stimulation with the use of Faraday current to these muscles. I will discuss further about this. Now coming to the positioning, I would like to elaborate this part. Positioning the hemiplegic arm in the lying position. When lying on the hemiplegic side, we do advise the patient to lie on the affected or the paralyzed side, during which how the position should be. Well, coming to the upper extremity position in particular, the hemiplegic arm should be kept forward at the shoulder with the elbow extended, and arm should be supported with the palm facing upwards. That means the forearm should be supinated. Unaffected arm should be supported forward on the pillow. A pillow can be placed behind the back, and further the lower extremities in this position should be bent at the hips, knees, and pillows can be placed in between. For lying on unaffected side, that is the non-paralyzed side, hemiplegic arm should be supported forward on two pillows. Now this position is especially important. The hemiplegic arm should be well supported forward. A pillow can again be placed behind the back, and both the legs again can be bent at the hips and knees with a pillow placed in between. This is the entire in general positioning of the patients while lying on the hemiplegic or unaffected side. However, to emphasize for prevention of shoulder subluxation, the arm should be particularly positioned in this manner. When we make the patient sit and the patient assumes an upright position, when he is already supported in the bed, supported sitting in bed, or when sitting in wheelchair, again very important is to take care of the weight of the arm, which should always be supported. In the bed, we can use pillows to support the arm and the entire upper extremity. Trunk should be maintained in midline, and pillows, as we said, under the unaffected arm can also be given as required to further ensure the trunk remains in midline. When sitting in wheelchair, a lap tray is an ideal supporting device for upper limb. Further, a pillow can be placed. It is important to ensure that height of the supporting device does support the weight of the arm. The arm remains in an upright position, however well supported, so as to avoid any bending of the trunk as well. So this is an ideal supporting strategy for upper limb when the patient is made to stand. Well, there are coming to proper handling and transfer techniques by the caregiver. It is an important part of caregiver as well as patient education. What this first image shows, the arm is being pulled from the distal end when patient is made to transfer or roll over on one side. So this is extremely wrong method of transfers or handling the patient, which will further aggravate or actually result in the problem of shoulder subluxation. So this is a wrong method which is shown in the first first picture. Well, the second picture or image shows correct method of shifting the patient or rolling, making him roll over on another side. The paralyzed side should be well supported at the scapular region. No pulling from the shoulder should be done by the caregiver or any other health professional involved in the transfer of the patient. Now this third technique again, in which we make the patient sit. Again, the back or the scapular region should be supported and never ever the shoulder should be pulled in an attempt to make the patient sit. When any therapeutic exercise is given in a weight bearing position of the upper limb, care should be taken that again the shoulder and the entire upper limb is well aligned in an erect manner, and whatever even weight shifts are given with proper support at the shoulder. Well, when the shoulder subluxation already develops, then what could be the management strategies? If it is associated with any kind of pain, cryotherapy, that is use of cold packs or ice packs, can be given over the painful region. As we know, cryotherapy can be given on the right-sided shoulder and should always be avoided on the left side when the patient has any cardiac condition. So patient having cardiac condition is a contraindication for receiving ice therapy. So that must be avoided in a patient with left-sided shoulder pain. And other electrical modality which can also be used is the transcutaneous electrical nerve stimulation, which will block the nerve carrying a painful stimuli to the brain, and that can also be used in any patient, and especially as we said, the patient having left-sided shoulder involvement. Stiffness is another complication of shoulder subluxation. So adequate mobilization of the scapula of the shoulder should be given. Initially, it could be passive range of motion exercises as the patient does not have adequate control to move the extremity actively. This can be followed later as the patient recovers in motor aspect. This can be followed with guided active movements. The important thing here to consider is whenever we are giving any kind of shoulder mobilization or exercises, it is very essential that we avoid the directions in which the shoulder is likely to get dislocated or subluxated, and those, as we know, are the inferior and anterior directions. So while giving any mobilization, though stiffness is present, inferior and anterior glide should always be avoided. Also, when we are doing or giving elevation at the shoulder, when we are doing abduction movement, the shoulder should always be rotated externally so as to avoid any impingement at the shoulder, and further above 90 degrees of shoulder abduction or elevation should be avoided, which results into more and more of inferior subluxation. Also, especially in the acute stage, there is some edema present over the paralyzed extremity. This edema should otherwise also be managed. However, in the context of shoulder subluxation, this edema aggravates or it adds to the weight of the upper limb, and again gravity and otherwise the pull will be more on the shoulder. So edema management is another aspect of management of shoulder subluxation. Well, coming to the electrical stimulation, the main effects of electrical stimulation are muscle conditioning, increase of the muscle force and voluntary control, and it augments other facilitation techniques targeted to the muscles. So this kind of electrical stimulation is considered to be very essential even in the prevention of shoulder subluxation, and later too in the management once the shoulder subluxation has already occurred. Now, the key muscles which should be targeted in this supraspinatus muscle, these muscles are identified to be having a fundamental role.
Yes, madam, more 5 minutes because we need to close Zoom meeting around 6:10. That's why we have two more talks.
So certain parameters should be considered about the electrical stimulation which are given in this thing. Also, electrical stimulation is considered to reduce the shoulder pain if it is associated with subluxation. Very important is the sling support, which is advised, suggested very often by the any health professional. Whenever it comes as shoulder pain and subluxation, a number of slings and other supports with different characteristics, design, and function are available, readily available in the market, and are very regularly used by our patients. The overall purpose of these slings are to realign the scapula, to regain the scapular symmetry, support the forearm in a flexed arm position, improving overall the anatomical alignment, and supporting the shoulder with a cup. So these different type of arm slings are you can see here. The advantages of these slings are they are very simple for caregivers and the patient himself or herself than other interventions. It can be combined with other treatments, and they are considered to especially reduce the shoulder pain. However, there is a criticism about the use of slings. They support the forearm in flexed position, which can facilitate increase in flexor tone and abnormal synergistic patterns. They themselves can lead to certain other complications such as reflex sympathetic dystrophy. They restrain the neurological as well as functional recovery, impaired body image, and also very importantly, they can obstruct arm swing during walking and other mobility functions of the patient. There is another possibility of taping the shoulder. So there are various tapes available and various methods of applying those tapes. This can be started in the initial recovery stage. Certain disadvantages that the tape may result into hygiene problems, skin reactions. Okay, well, overall, to summarize this talk, as we have seen that shoulder subluxation is a very frequent upper limb complication. Evidence-based intervention is required for its effective treatment, and current treatments are not proved and not considered satisfactory or effective.
Hello.
Thank you everyone for your patient listening.
Yes, please apologize, madam. Actually, we are running according to the program. Hope you understand. Yes.
Thank the audience for their patient listening to.
Yes. Any questions? Any questions to Dr. Aisha Akulwar regarding this topic? Shoulder subluxation in stock clinical applications. If you have any questions regarding this topic, just you can text us in chat box. We'll be asking you behalf of you even after the completion of the conference. Any questions? You can raise your hand. Yes. Thank you so much, madam, for participating in this event. On behalf of organizing committee members of Physiotherapy Congress 2021, we want thank you for excellent presentation. Looking forward to meet again next time. In physical event in 2022, we are going to plan in Dubai in the month of May. Hope we expect your presence as a speaker for this conference.
Yes, sir. Thank you so much.
Yes, madam. You will be getting electronic certificate as well as book, as well as participation certificate within a couple of days after the completion of the conference.
Thank you.
Yes. Thank you very much, madam. Have a nice day. Bye. Thanks for your patience also. Next, we ask Dr. Sahman Saleh, the Tehran University of Medical Science from Iran. The topic will be ultrasonography, measurements of plantar fascia thickness and echogenetic in individuals with and without plantar fasciate reliability and group differences. Yes, sir. Go ahead by sharing your slide. Hello. Hello, Dr. Sahman Saleh. Did you hear my voice? Or else Dr. Saeed Wahedi from Iran. Mohan Gagi Abduli University from Ardobili from Iran. If any one of two members are ready, just you can start sharing your slide.
Hello?
Yes, sir. I'm going to share your slide. Please, I'm going to share your slide. Just as soon as completion of your slide, just tell me the next. I'll be changing from here.
Okay.
Yes, you can go ahead.
Yes. Hello. Again.
Yes, go ahead, sir. Yes, start presenting.
Okay. Hello. Good evenings. Thank you all for being here. Today, it's my honor that you are joining me for this presentation. This presentation is about the ultrasonic measurements of plantar fascia thickness and echogenicity in individual with and without plantar fasciitis, reliability and group difference. The chronic plantar heel pain, also known as CPHP or chronic plantar heel pains, it also known as heel spur syndrome, plantar fasciosis, and plantar fasciitis. Plantar fasciitis is an overuse syndrome that developed over the time and is a result of the repeated stresses to plantar fascia. It's a degenerative syndrome, not an inflammatory process, and of the plantar fascia and from the repeated trauma to the origin of the calcaneus, and the degenerative process is more than bold than inflammatory natures. Prevalence of the plantar fasciitis is estimated to 10% in adults, and in the athletic is maybe rise to the 31%. Both male and females are experience these pathologies, but in the age of the 40 to 20 to 50 decades is more the prominence. The etiology of the plantar fasciitis is multifactorial, and some of the approach has been known to this pathology. Myofascial approach by Meyer's anatomical trains, and movement approaches by Sarman's biomechanical approaches in the biomechanic approach, and the medical approaches in the diagnosis for calcaneal heel spurs. Several intrinsic and extrinsic factors lead to the development of the plantar fasciitis. Increase the body mass index, prolonged standings, long time walking and running, improper footwear, decrease strength and gastrosoleus muscles, decreased dorsiflexion of the ankles and the leg. Length discrepancy have shown association with development of plantar fasciitis. Next, please. The diagnosis of plantar fasciitis also there is no gold standard for diagnosis of plantar fasciitis, but some clinical examination can provide valuable information about the diagnosis of plantar fasciitis. Clinical examinations also refer to APTA classification and function, disability, and health from the orthopedic section of the APTA diagnosis, and have some criteria for this, and another instruments that used for the diagnosis of the plantar fasciitis imaging. Some imaging protocols such as plain radiography, magnetic resonance MRI, and ultrasonography has used for the diagnosis of the plantar fasciitis. Also, ultrasound imaging is a non-invasive instrument that used to help physical therapists and medical doctors to diagnosis of the musculoskeletal issues, such as some problems or tendinitis, muscle pains, and strained joint and ligament sprains, and also used for the diagnosis of inflammations. Ultrasound imaging and musculoskeletal ultrasound is a dynamic, safe, and real-time approach, and is very good for use of the use of physical therapies to diagnosis of musculoskeletal problems. You know, because of the advent of technologies, will be how more clear and could help us in the diagnosis of musculoskeletal problems. When we take an ultrasonography of the plantar fascia, we see the change in the thickness and the echogenicity. You know, in healthy subjects, the thickness of the thickness of the plantar fascia in origin is less than 4 millimeters, and the echogenicity is high in this and in the fascia, but in the patient with the plantar fascia, the thickness is more than 4 millimeters, and the echogenicity decrease in this patient. A previous study have found the change of thickness and echogenicity in a plantar fascia subject with the plantar fascia compared to healthy controls. However, the protocol of measuring of the thickness and echogenicity is not consistent among the study. For instance, some studies measure subject in the prone position, whereas other measures in the supine position. Furthermore, studies have measured the plantar fascia thickness at various stations, as show that Macmillan and colleagues that plantar fascia usually take place in the insertions. This inconsistent in a method limits our ability to compare results between studies. There is little data on the reliability of ultrasound variable of plantar fascia, such as the thickness and echogenicity in subject with plantar fasciitis. Furthermore, ultrasound variable of plantar fascia measure the different stations have been rarely compared between subject with and without plantar fasciitis. Therefore, the primary purpose of the study was to determine the intra-rater reliability of plantar fascia thickness at the insertions 1 centimeter and 3 centimeter distal from the plantar fascia insertions and echogenicity at the two regions using rehabilitative ultrasound imaging in individual with and without plantar fasciitis. The secondary purpose of the present study was to compare the plantar fascia thickness and echogenicity between these two groups. Intra-rater reliability studies and the group difference of the plantar fascia thickness and echogenicity, 20 healthy control subjects and 20 plantar fasciitis subjects. Inclusion criteria: people with the plantar fasciitis diagnosis by ICDH of the orthopedic section of the opta and age 22 50 years. Exclusion criteria include direct trauma to the foot and ankle, fracture of the foot and ankle, tarsal tunnel syndrome, and disc herniation, and in the end is pregnancy. Demographic variables were recorded thickness and echogenicity of plantar fascia by use of the US imaging B-mode units, Honda Electronics 5 to 10 megahertz linear hertz transducers, and the length of the 5 centimeters was used to measure the thickness and echogenicity of plantar fascia. The imaging settings didn't change during all measurements. Participants were positioned in a prone positions with his arm relaxed and the sides and the pillow placed under their heads. Both legs were held in extensions with the feet hanging freely from the edge of the table. In both groups, only one foot was used for measurements. Either the effects of the foot in unilateral plantar fasciitis or the dominant foot in the bilateral plantar fasciitis in the plantar fasciitis groups, and the dominant foot in the healthy group control. All measurements were made with the ankle joint in a neutral or slightly dorsiflex position. Before imaging, electroconductive gel was applied to the US transducer and plantar surface of the foot. The transducer was placed longitudinally to medial-inferior surface of the calcaneus, and the US transducer will longitudinally move the medial-inferior surface of the calcaneus to achieve a clear image of the plantar fascia. As you show in the pictures, you see the location of the ultrasound. Please, the next slide, please. Okay, you see the placement of the probes on the plantar surface, inframedial of the foots in the prone position and slide neutral to slide dorsiflexions. Thickness was measured from the longitudinal view of the heel at insertion 1 and 3 centimeter distal from plantar fascia insertion at the calcaneal tubercle. Echogenicity was determined using the mean of the gray level in the select region of the interest, also known as ROI, region of interest. 2 ROIs were selected for evaluations of the echogenicity of plantar fascia. 1 ROI located between insertion and 1 centimeter distal from plantar fascia insertion, and another ROI between 1 and 2 centimeter distal from plantar fascia insertion. Length of the ROI was set 1 centimeters, but the width was adjusted based on the plantar fascia thickness in each measurement. Okay. Okay, you see the diagram and the categorizing the layers of the sole of the foot in the insertion of the plantar fascia. In the first layer, you see the skin and subcutaneous skin, fats, and then plantar fascia. And under the plantar fascia, in these sections, you see the flexor rhomboideus muscles and the margin of calcaneus. In the next, you see the image of the plantar fascia was taken by ultrasound devices, the measurement with the imaging software. You see the insertion of the calcaneus, insertion of the plantar fascia on the calcaneus. It's 1 centimeter distal and 3 centimeters distal to east. You in these 3 points, the thickness was measured. Also, you see the excuse me, previous slides. Sorry. Okay. Previous. Okay. Thanks. You see the ROI1 and 2, the 2 regions are selected to the analyzing of echogenicity. Please. Okay. There was no significant difference between the 2 groups in the demographic status, and 2 groups were matched in this study. Okay, next. ICC or intra-class correlations show an excellent reliability, and the SEM, standard error of measurement, and MDC and or minimal detectable change, and LOI limit of agreements confirm our reliability and our ICC. Next. Okay, you see the Brandt-Altman's graphs of the thickness at the insertions of between 2 groups, plantar fascia and healthy groups. You see the Brandt-Altman graph of the plantar fascia groups and healthy control groups in ROI1 by use of the Brandt-Altman graphs, plots. Okay, next. Okay, the healthy controls groups had less thickness, more echogenicity than the plantar fasciitis groups, as you see in the last. Okay, in the all of the selected points, the thickness was less in the patient with patient without plantar fasciitis, and a patient with the plantar fascia or plantar fasciitis, the thickness is more than the healthy groups in the 3 points that we select for the examination. Okay, next discussion. Okay, next. Excellent relative reliability was observed in the both groups for the variables of both groups. Our result was in line with the BC bones thickness and ecogenicity of the plantar fascia in a difference point of 12 healthy subjects in the supine positions, good to excellent reliability for plantar fascia thickness at insertions 1 and 2 and 3 centimeter distal from the insertion, and plantar echogenicity ICC is reported more than the it's in an excellent range. And Nahe and colleagues reliability of they measure the reliability of in their study, they measure the reliability of plantar fascia thickness at the insertions and 1 centimeter distal from the insertion in 12 healthy subjects in the prone positions. They conducted they conclude that the high reliability was in their study. And Johnson and colleagues excellent intra-rated reliability for the plantar fascia thickness at the insertions in their subjects with the plantar heel pains. Their subjects was 17 subjects in their studies. In our study, the highest intra-rated ICC intra-class correlation for the thickness was observed in the insertion of the healthy groups and the 1 centimeter distal from the insertion of the plantar fascia groups. The highest intra-rated ICC, what the echogenicity was observed in the ROI2 of or region of interest 2 in the both groups, and the ICC for healthy and plantar fascia groups respectively. One of the limitations in the most previous reliability study of the plantar fascia was that ICC from the relative reliability was not clear, but in our study, this is so clear that we use the ICC 3.3, the model of the ICC that we use. Okay, the findings indicate that okay, absolute reliability variable including SEM, MDC, LOA, and blunt Altmans plus confirmed the reliability study. In the present study, threshold of the MDC value of all variables in the both groups were more than difference between measurement in the 2 sessions. In the present study, in the both group, the highest thickness was at the insertion and the smallest thickness was at the 3 centimeter from the insertions. Plantar fascia thickness more than 4 millimeter using the ultrasonography is indicated plantar fasciitis. In conclusion, the finding of the intra-reliability study have shown a range good to excellent relative reliability for plantar fascia thickness and echogenicity in all measurement stations in a subject with and without plantar fasciitis via ultrasonography. Also, SEM, MDC, LOA value and blunt Altman plots confirm the reliability of the measurements. Ultrasonography for measurements of plantar fascia thickness and echogenicity is a reliable method and can be used for therapy and research subjects in a subject with plantar fasciitis. In addition, the findings show that plantar fascia characteristics not only at insertion but also in the other point of the plantar fascia are affected by plantar fasciitis. Thank you very much and have a nice.
Yes, this was the presentation from Dr. Sahman Saleh. Any questions regarding this topic? Any question? I think there is no question, sir. If you have any,
Okay.
yes, if you have any questions, you can text in chat box. We'll be asking behalf of even after the completion of the conference.
Thank you. Have a good night and have a good times. Thank you very much for this good conference, and thank you.
Yes, thank you very much, sir. Looking forward to
Good evening.
yes,
Good evening.
yes,
Thank you. Good evening.
yes, sir. Sir. I like to inform you that we are going to organize this event in physical way in the month of May in 2022. To join this conference as a speaker, we ask you to get ready now itself. You understand?
No, no, no.
Actually, we are going to organize physical event in the Dubai in 2022.
Okay.
So in the month of May first week we are going to organize. If you are willing to join as a speaker,
Yes, it's for honor for me. Yes, yes,
yes,
yes.
you can get ready now itself with flight tickets.
Thank you very much. Thank you. Okay.
Yes,
Yes.
thank you very much, sir.
Thank you very much. Have a good night.
Good night. Yes.
Okay.
If you go to the last,
Bye.
yes. Thank you very much, sir.
Thank you very much.
Yes, if you go to the last speaker of the conference, that is Dr. Sahed Bhai, a PhD student in sports physiotherapy, cardiovascular from Mohagahgi Rabdal University from Iran. So, if you are in Zoom meeting, just you can start sharing your slide so that we can conclude the day 2 conference. Hello, Dr. Sahed. We request you again. Yes. So within 5 minutes we are going to conclude our conference. Yes. If you go to vote of thanks, thank you very much to all the participants. Thank you very much to all the participants, those who joined this webinar on third virtual conference on physiotherapy, physical rehabilitation, sports medicine that was held yesterday as well as today, October 15 and 16, virtually during this period having different time zones. Our most sincere thanks to all the keynote speakers, plenary speakers, students, delegates, general collaborators, media partners who have joined from different destinations around the globe for their support and cooperation. Let us thank speakers who have responded so well to our invitations to participate in this conference. We have resourced several papers which will form the basis of our discussion in the various sessions. Let us thank you all for associating in this conference by your presence. Once more, a special thanks to Program Manager Mr. Kevin Brown as well as Mr. Madhu for his continuous effort in putting all together under one platform in this online event. If we go to the keynote speakers of the day 2, that is Dr. Silvio Di Rocco, Dr. Irina Kolov from Albania, as well as day 1 of the speaker is Dr. Sheila Rone from USA. If you go to plenary speakers of the day 2, that is Dr. Thaminder from Saudi Arabia, Dr. Abdul Elisa from Saudi Arabia, Dr. Lee from Korea, Dr. Chiraz from Qatar, Dr. Mahesh Javari from UAE, Dr. Jos Sedad from Denmark, Dr. Edono from Albania, and Somya Prasad from USA, from the organization that Setting Stones Group USA, Miss Kavita Bakshi from Uttarakhand, India, and the last speaker of this conference, Dr. Saman Saleh. So, if everything goes well in 2022, hope we will join in physical event on same topic, that is physical therapy, physical rehabilitation, as well as sports medicine. So we are considering these 3 topics in one platform. We are planning in the month of May, second week. The venue will be Dubai. I am especially thankful to all the participants, especially delegates like Dr. Sihare Baron Dr. Takrini, Dr. Alumila Ganeshan. Yes. Once more, I would like to thank all the participants. Hope we can collaborate in the future in physical event. If you start registration by now itself, you will be getting 30% discount on your registration fee as well as accommodation fee. If you register now itself, officially we will be sending letter of invitation. You can apply through Dubai Embassy. Also, like electronic booklet as well as send electronic certificate, participation certificate will send through email within 3 to 4 working days after the completion of the conference. Finally, we extend our appreciation to each of you for your participation in this online conference. Thanking you once again. This is signing off Bhupati. Any questions? Just we have 2 to 3 minutes. We'll be concluding our conference. Any questions? I request Dr. Baranko, if you are joining, if you are going to participate next time, we ask you, sir, to join as a speaker, because last March conference, April conference, you have joined as a delegate. Now you are participated as a delegate. I request you, you can select a simple topic. You can join as a speaker for this conference, as you are the senior professor from Qatar. Also, I request Dr. Takroni from Saudi Arabia to join as a delegate, keynote speaker for upcoming Dubai event. So, as well as Dr. Abdullah also. Any questions? Sure. Thanking you. Good night, good afternoon, good evening as well. This is signing off Bhupati.